I will use this one, it's better. It's 12:15. ما تصير هذا it's okay. لا ما استعمل على ابنين على هذا. Thank you. Assalamu alaikum. So today our subspecialty lecture about choroidal disease. So I will mention the most important choroidal disease that you should encounter during your ophthalmology career. Today I will speak about choroidal vascular Brooks membrane disease, choroidal hemangioma, bilateral diffuse uveal melanocytic proliferation, and choroidal dystrophy. So start with the choroidal vascular Brooks membrane disease. Please be quiet. I want to speak so that you can hear me. So we classify it to choroidal neovascular membrane, polypoidal choroidal vasculopathy, central serous choroidopathy, and Uvl Effusion syndrome. For choroidal neovascular membrane, you have a lecture already, and I think it will present it enough. So I will not mention about choroidal neovascular membrane. So let's see the polypoidal choroidal vasculopathy. The other term is posterior uveal bleeding syndrome, and this is characterized by exudative maculopathy, subretinal hemorrhage, pigment epithelial detachment, and urosensory detachment. It was found that the prevalence more in Black, in Japanese, and in Asian than in white people. The age of presentations range between 50 to 65 years, more in female. However, the reports from Asian reporting that it is more common in male, and the age of presentation is younger than the reported in Western countries. Usually bilateral and usually located in the macula. Sometimes you have pre-papillary location or location other than the macula. It was found that there was a systemic association like severe thrombocytopenia and hypertension, but it was uncertain. The role of hereditary and environmental factor is also uncertain. And remember that the PCV originated from inner choroidal vasculature or the deep vascular channels. The pathogenesis, till now, it is unknown. It is controversial. And some, they regard it as it represents a subtype of neovascular AMD. However, all agree that atherosclerosis in the choroidal vessels are the pathological factor. The classification of PCV, it could be either quiescent, which is the polyp can be presented with the absence of fluid, absence of exudate, absence of hemorrhage. It can be exudative, it means exudation in any form, like in urosensory detachment, pigment epithelial detachment, and subretinal exudation. Or it can be hemorrhagic. Hemorrhage can present with or without exudation. The clinical findings, usually the clinical examination revealed orange, red, elevated lesion, and as I mentioned, usually in the macular area. The fluorescein angiography, it is not conclusive, and sometimes it shows you looks like occult choroidal vascular membrane, in which you have leaking of undetermined source. However, the ICG is the main test that you should do it to rule out PCV. And it is characterized by presence of nodular polypoidal aneurysm, or it can be multiple. So this is nodular. And usually you have this interconnecting channel arising from the deep choroidal vessels. So the presence of orange-red subretinal nodules with corresponding ICG finding, it is a pathognomic of PCV. PCV, diagnostic by ICG. Sometimes even you can appreciate the pulsation in the polyp, but this is, you can show it during video process ICG. The natural cause of PCV is variable. Recurrent bleeding, leakage can happen, and with visual loss. And the visual loss usually secondary to choroidal atrophy or scarring. Reports found that if you have a reddish orange nodules with or without small subretinal hemorrhage, usually they have a benign clinical course and stable vision. PCV can induce ischemic changing, inflammation, and can cause choroidal neovascularization. Again, this is a typical picture of orange-red sub-RPE lesion in the macula. And here you can see the network of channels that we called it like a clusters of grapes. This is by ICG. And here, this is a nodular polypal aneurysm. This is inactive, and this is active. How you differentiate? Usually, the active is surrounded by a halo of hypofluorescein, and this is corresponding either to fluid or hemorrhage. This is inactive. This patient presents with PCV with RPE hemorrhage, and you can see the crescent shape of pigment epithelial detachment to hemorrhagic pigment epithelial detachment, and you can appreciate this multiple aneurysms. The OCT show elevation of the pigment epithelial detachment. PCV can be presented, as I mentioned, with exudative macular detachment, as this is in one patient. You can see the irregularity of pigment epithelium with a polyp, and usually you can distinguish the polyp from the CSR. Both of them, they have the double line sign in which you have separation of the RPE from the Brooks, but usually in polyps, it is hyperreflective, not hyporeflective, that the one that we are seeing in CSR. And this is the Fluorescein Angiography demonstrating the multiple nodules deep in location. Unfortunately, this patient, despite our effort to laser him PDT, he ended with the legally blindness with massive submacular fibrosis, telling the fact that PCV can produce a profound visual loss. This is the right eye of the patient, and you can see serous pigment epithelial detachment, and this is corresponding by the Fluorescein Angiography, and you can see the regulation of the RPE, and sometimes you call it like M-shape detachment. What about the treatment? Thermal laser, especially for extrafoveal PCV, photodynamic therapy, per my experience and per report, is the mainstay treatment of PCV. Anti-VEGF therapy, if there is a choroidal vascular membrane, combined therapy, anti-VEGF with PDT can be optional for PCV-related CMVM. So by this, we finish PCV. Let's go to the third entity, which is a central serous choroidopathy, which is a very important subject in which all the ophthalmologists should be aware about it. It is old disease and was named as central recurrent retinitis in 1866. Usually occur in young to middle-aged men, and it's characterized by serous detachment with pigment epithelial detachment in posterior pole. The common symptoms: central scotoma, metamorphopsia, micropsia, dyschromatopsia, and blurring of vision. Most of the cases idiopathic. However, there is a secondary, which is associated with steroid, either endogenous or exogenous use. There is pathogenesis, some predisposing factor and risk factor. And usually it is related to the hyperdynamic choroidal circulation and choroidal vascular hyperpermeability. The fact that increased hydrostatic pressure in the choroid lead to the breakdown of RPE barrier. And this is leading to the leaking of the fluid from the choroid through the subretinal and sub-RPE spaces. And usually you have also defect in the retinal pigment epithelial digestion. The ICGA also show area of hypofluorescein, and this is corresponding to the choriocapillary non-perfusion, and this is with subsequent choroidal venous dilatation and congestion, telling the fact that probably it is arising from the angiospasm of the choriocapillaries with subsequent dilatation of the choroidal venous. Risk factor, number one, stress. And many reports and also our experience show that psychiatric disturbance and mental disturbance is increase the risk of CSR in these people. And the association of CSS proven by a report came from Yanouzi with type A personality because it is related to the increased catecholamide levels, which might trigger vasoconstriction of choroidal vessels by stimulation the sympathetic nervous system and adrenergic receptors. Other risk factor, or the secondary, let's say, secondary CSR, it is related to the corticosteroids, whether it's exogenous and endogenous. And this is reported. For example, patients with systemic steroids, which you're using for autoimmune disease or after renal transplant, they have the tendency to develop CSR. The use of topical steroids, like intra-articular, intranasal topical steroids, also increase the risk of CSR development. And the disease is associated with high endogenous corticosteroid, like Cushingoid disease and pregnancy. The steroid-related mechanism to the CSR, it was proposed maybe due to choroidal vasoconstriction, which is by reducing the nitric oxide production, or by direct increase of the permeability of the blood vessels and RPE cell tight junction damage, in which lead to breakdown of outer return layer and leaking of the fluid. Or it might be reserve the polarity of the RPE cells, which cause them to pump ion into the subretinal space, then the fluid enter the subretinal spaces by osmosis. Other risk factor was also studied for the idiopathic one. For example, it was found as abnormal coagulation platelet aggregation, and this is proven by aqueous sample cytokine analysis showed lower platelet-derived growth factor. Hylobacteria pylori infection also was reported, and the patient who received treatment against this bacteria show respond in the CSR. Hypertension, smoking, antibiotic use, antihistamine, alcohol consumption, and allergic respiratory disease and obstructive sleep apnea, all it was proposed to cause CSR. Also glaucoma, and the mechanism suggested by increased choroidal blood supply to the optic nerve. So this is the clinical picture of CSR. Usually you have as subretinal fluid, and you can see here, which is corresponding probably to the leaking point. This is acute form of CSR. The patient present with visual acuity 20/200. This is another example in which you can see some yellowish dose suggesting of high protein concentration in the subretinal fluid, and this is a chronic form in which really looks like a Best disease. Sometimes if you have a chronic CSR, this material gets precipitated and form like a pseudo-hypopian picture that we are seeing in the Best disease. And this is pigment epithelial detachment, sometimes present without neurosensory retinal elevation, which is manifest as only orangish lesion located at sub-RPE level. The test that you needed to document your diagnosis is the fluorescein angiography. And you have a different patterns on fluorescein angiography by CSR, and this is depending on the protein concentration of the fluid. For example, this is Incuplot, which is represent as pinpoint in the early phase, and then concentrate diffuse out at the late phase. And you can see the pooling of the fluorescein in the subretinal space, and this represents pigment epithelial detachment, which is pooling of the dye underneath the RPE. As the arrow indicated, you can see this is the lesion, and this is the leaking point. Other form, like a smokestack, you have here like a smokestack. The leak started as a pinpoint in the early phase, then gradually tracked up, and that's what we call smokestack. Sometimes it diffuse more and cause like a mushroom shape, and sometimes become like umbrella-like appearance. The umbrella-like appearance is present in 10 to 15% of the cases, and as I mentioned, is related to the concentration of the protein in subretinal fluid. The advantage of the fluorescein angiography, you can see the pigment epithelial detachment as here, and also you can see the multiple window defect representing the chronicity of the CSR, because it can cause RPE damage. And this picture show in the chronic CSR, sometimes even you have a descending tract secondary to loss of RPE because of persistent subretinal fluid. Other form of pattern of fluorescein angiography, you can have a multifocal CSR, in which you can see multiple sites of pinpoint hyperfluorescence that leak at the late phase. The fluorescein angiography also help you, please when I make the lecture, nobody talk, please, unless if it is necessary. Thank you. Fluorescein angiography also help you to see the situation of the other eye. For example, this eye, the patient was asymptomatic. This is the same patient that presented with a smokestack appearance CSR. In the right eye, he showed pigment epithelial detachment, although he is asymptomatic. So also it can guide you to the diagnosis of bilaterality. The second test that you have to order is the ICG. And usually ICG show dilated choroidal vasculature in the early phase and choroidal hyperpermeability in the late phase, as this slide showed. Sometimes even you can see punctate hypofluorescein, which is corresponding to the choriocapillaris occlusion. OCT is very important in CSR, and this is help in assessment of the disease progression and treatment response. For example, this OCT show the amount of subretinal fluid. However, you can see the integrity of the outer nuclear layer ellipsoid is intact, indicating that patient probably have a good visual prognosis after treatment. Sometimes even it can demonstrate the subretinal yellowish as hyperreflective spots. It shows you also the pigment epithelial detachment. The EDI also important to see the structure of the choroid. And also the OCT is help you to differentiate the CMV and PCV from CSR. For example, this patient, as you can see, he has a serous detachment, which is corresponding to the multiple pinpoint leaking. And OCT show a multiple pigment epithelial detachment. And if you remember the pigment epithelial detachment, it is doming, but usually it is smooth, and it is hyporeflective compared with the PCV. This is very important to distinguish the CSR from the PCV by the appearance of the pigment epithelial detachment. So this patient, he has a multiple pigment epithelial detachment. Also, OCT help in diagnosis of the other eye. For example, this other eye patient is asymptomatic, and he presents pigment epithelial detachment, but because it is away from the fovea, he is not asymptomatic. Fundus autofluorescein, also important tool for at least to see the progression of for the CSR. And usually in the acute phase of the disease, it shows hypoautofluorescein, and this is corresponding to the fluid that leak from the leaking point. And sometimes also you can compare the subretinal yellow dots. It shows a hyperautofluorescence by the autofluorescein test. And also in chronic CSR, you can see hyperautofluorescence, and this is corresponding to the protein in the fluid and also corresponding to the RPE damage. Other tests you can investigate for multifocal electroretinography and microperimetry, but the previous three tests is really very important to get the final diagnosis of CSR. For example, this patient, he has CSR, and you can see by autofluorescein, he has a hypoautofluorescence, and this is corresponding to the leaking point that shown by fluorescein angiography and corresponding to the fluid that's shown by the OCT. So OCT, autofluorescein is really important for diagnosis of acute CSR. The same patient, the other eye was asymptomatic, but the autofluorescein corresponding to the fluorescein show pigment epithelial detachment, which is corresponding by hyperautofluorescein, and hypoautofluorescein, which is corresponding to the leaking point. But as I mentioned, because it is away from the macula, the patient is asymptomatic. Differential diagnosis of CSR, optic pit is very important, and this one you can rule it by clinical examination. AMD, you can rule by fluorescein angiography, by OCT, PCV, OCT, and ICG, and other inflammatory infectious disease, autoimmune and vascular disorder, and usually these you can, they are associated with the systemic manifestation. For intraocular tumor, you can order for ultrasound to rule out the tumor. What about the management? Starting with a natural history, it is a self-limiting. Spontaneous can occur up to 90% of the cases. recurrent in 50% and can develop at any time. However, it was found 15% of the recurrent cases occur in the first year. So it is a good news and bad news because of recurrence that make the patient upset. It was found also the history of psychiatric illness is associated with a higher rate of recurrence. And it was found that severe reversible visual loss is only 6% of the cases, which is really usually have a benign course. And the visual loss secondary to RP atrophy and CMVM. What about the treatment? Observation in most of the cases, especially with the acute one. Photodynamic therapy can be recommended for poor presenting visual acuity and for the chronicity, if it is more than 3-month duration. And photodynamic therapy, you have two options, either conventional or safety-enhanced PDT. And safety-enhanced PDT reflecting that if you can decrease the duration of the laser pulse or decrease the dosage of verteporfin in attempt to decrease the complication of PDT. And usually in our practice and per previous report, you are using the safety-enhanced PDT, not the dose that you are using to treat CMVM. Argon laser photocoagulation also we are using, especially for the extramacular leak, and also micropulse diode laser. There is other treatment like transpupillary thermotherapy, intravitreal anti-VEGF therapy with or without PDT, rifampicin, systemic acetoacetamide, anti-adrenergic blockage, and beta blocker. I mean, many medications is only under trial, but the main state of management of this disease is observation, PDT, and laser for extramacular leak. Here is one of my patients. He presented with acute CSR, and you can see the multiple leaking, and with the fluid underneath the retina with pigment epithelial detachment. I intend to follow up him with within 4 months. He completely resolved with visual acuity 20/20. However, other patient he presented with acute CSR with drop of vision to 20/200 and really has a massive subretinal fluid, and he asked for treatment. So I did for him laser photocoagulation at the leaking point. It is really good location. It's extramacular. So after laser, macula get flatter, and you can see the laser scar. Vision improved to 20/20. Laser photocoagulation also can use for the chronic type of CSR, like this case I presented before. It's a chronic CSR, and with extra foveal leak. So I did laser, and the fluid completely resolved, and even the crescent shape is disappeared, the deposits. So laser, it's help for the extramacular CSR. What about photodynamic therapy? It is really very good result per experience and per report, and usually indicated for the subfoveal multiple leak. For example, this patient in which the fluid resolved with some precipitation, and vision returned to 20/25. By this, we end the CSR. Let's go now to the uveal effusion. The uveal effusion, just to go back to the basic, you remember that the suprachoroidal area should be dry, should be dehydrated. And the proposed mechanism that to keep the suprachoroidal dry is by three pressure, which is the hydrostatic pressure, which is inside the blood vessels, the colloidal osmotic pressure, which is related to the protein concentration inside the vessels, and by intraocular pressure. By this mechanism, all the fluid get pumped out to the scleral canal and get out. And that's why our suprachoroidal area should be dehydrated from gut. So what is the pathophysiology that give you uveal effusion? Anything disturbing these factors can give you choroidal effusion, either hydrodynamic, inflammatory, neoplastic, or these conditions that are associated with abnormal sclera. So let's start with idiopathic uveal effusion syndrome, the most complicated one. It is a rare ocular disorder present in healthy middle-aged male. It is usually bilateral. But sometimes old man can present with unilateral manifestation. And diagnosis is based on a characteristic clinical finding and exclusion of other known causes of uveal effusion. And it is associated with this congenital scleropathy. which is defined by abnormal accumulation of glucosaminoglycans-like deposits and thickening of the sclera in the absence of any systemic disorder. Clinical findings. It's characterized by accumulation of serous fluid in the ciliary body and choroidal, and this is what we call a cilio-choroidal detachment. Non-recombinant retinal detachment is very important and usually inferiorly because of shifting sign. Dilated and episcleral blood vessels, blood in Schlemm canal, normal intraocular pressure, and sometimes you have mild vitreous cells with lipotis spots corresponding to retinal pigment epithelial damage. Other findings which show high level of protein in the CSF fluid. And this is the picture. Usually, by clinical examination, you have like a solid choroidal elevation with a smooth convex surface. And sometimes you can see the ora serrata without indentation because of choroidal detachment. And this pigments, what we call lipotis spot, which is corresponding to the RPE damage with subsequent RPE hyperplasia. And this is the inferior detachment in which the patient usually have inferior detachment because of the shifting sign, gravity, the fluid get gravitated inferiorly. The B scan shows thickening of the choroid with inferior detachment, and also you can list the shifting sign in, during your your B scan examination. The behavior of the lipoid skin appearance in the fluorescein is usually show hypo and hyperpigmentation corresponding to the RPE damage and corresponding to the pigment hyperplasia. Treatment. The mainstay of the treatment for the choroidal effusion is the scleral thinning procedure because the abnormality is the sclera, so you have to do something with the sclera. And this is by quadrantic partial thickness, either sclerotomy or sclerotomies. Pars plana vitreoretinal is sometimes indicated, especially if you have detachment, retinal detachment. Vortex vein decompression also was done, previously hypothesized, but we are not using this technique commonly because risk of bleeding. Please pay attention that the prophylactic treatment with a scleral thinning procedure should be considered for asymptomatic fellow eye prior any intraocular surgery. So any patient presented with choroidal effusion, think to do something for the sclera and the other eye if planned for surgery. So what is the differential diagnosis of the secondary uveal effusion? First, scleropathy, and the scleropathy characterized by abnormal thickening of the sclera significantly alter the choroidal fluid dynamic and may cause uveal effusion. Because usually in the thick sclera you have compromised the vortex vein and you have difficulties in the drainage of the fluid from the suprachoroidal area to outside. And that's why you have accumulation of the fluid and choroidal effusion. The scleropathy can be congenital in form of nanophthalmos, which is a form of microphthalmos that characterized by small eyes, thick sclera. The axial length is less than 20 millimeter. Usually they don't have other identifiable ocular or systemic abnormality. Usually they are hyperobic with more than +7 cylinder. Other findings, you can have small corneal diameter, shallow anterior chamber, high lens to eye volume ratio, angle closure glaucoma. Uveal effusion and non-retinal detachment can occur spontaneously or can occur during the surgery or after surgery. Secondary scleropathy, like in cases of amyloidosis and mucopolysaccharidosis. The factors that cause hydrodynamic effusion can cause choroidal effusion, as I mentioned before, like what happened in ocular hypotony. Usually you have it after surgery, and usually after glaucoma filtering surgery is common, and drainage device surgery, and also after wound leaking. Elevated uveal venous pressure, like for example, this is cause increased transudation from choroidal vessel to the suprachoroidal space and choroidal effusion, like in CC fistula or dural AV fistula, Sturge-Weber syndrome, and after scleral buccal surgery. So anything that increases the uveal venous pressure by compromising the vortex vein can give you the uveal effusion syndrome. Malignant hypertension, like example in severe renal disease and pregnancy also can give you choroidal effusion. Malignant hypertension or hypertensive choroidopathy is very important to mention about it. It is caused by choroidal ischemia, and choroidal ischemia causes a fibrinoid necrosis at the level of the choroidal capillaries, and this is cause atrophy and pigmentary hyperplasia of the RPE. And usually the manifestation either Elshing spots or cigarette streak. The Elshing spot, which correspond to round, deep, and gray-yellow patches of RPE. The cigarette streak because of linear hyperpigmentation streaks along the choroidal arteries. Malignant hypertension sometimes present with cerebral detachment and visual loss. Other differential diagnoses other than that, the scleropathy and hyperdynamic effusion, inflammatory factors, something which is increase the protein content of the choroidal vessels, which lead to excavation of the fluid outside. It can happen after trauma, intraocular surgery, PRP sometimes happen, also cryo. Inflammation of the sclera, whatever is the cause, giant cell arthritis, and granuloma, like in Wagner granulomatosis. SLE, polyarteritis nodosa, and antiphospholipid syndrome. So any inflammation that increases the protein content of the vessels can lead to choroidal effusion. Neoplastic also, tumor can cause. And the most common one is choroidal metastatic tumor, malignant melanoma, and lymphoproliferative disorder or melanocytic proliferation. So by this, we end the choroidal effusion, which is one of the more common choroidal disease that you should encounter. Let's go to the third subject, which is a bilateral diffuse uveal melanocytic proliferation. And this is very important to know because this cancer that present with the choroidal manifestation, and that's why, as ophthalmology, you should know this disease entity. So it is a paraneoplastic disorder, proliferation, and characterized by diffuse thickening of the choroid, reddish or brownish choroidal discoloration. You see the choroid is very red. Looks like the one that we are seeing in the Sturge-Weber syndrome. So characterized by choroidal discoloration, certain detachment, and cataract. And the Dumby lesion, it's appear a reddish area of depigmentation with RPE loss, and usually it is associated with hyperfluorescein because of RPE damage and window defect. The usual association is a systemic cancer, like in cancer of ovary, uterus, lung, rarely with colon, pancreas, gallbladder, and esophagus. Circumscribed choroidal hemangioma, this is one of the choroidal diseases that also you should know it. It is in general, choroidal hemangioma, you have either circumscribed or diffuse Sturge-Weber syndrome. For the circumscribed, usually it is associated without systemic association. Isolated without systemic association. However, for the diffuse Sturge-Weber syndrome, usually they have systemic manifestation. So I will speak mainly about circumscribed type, in which usually it is common than the other one. It can happen in any sex, male and female, age range between 38 years to 47. And as the arrow indicated, which is show orange, red tumor overlying with some changing in the RPE. Sometimes even you can see yellow spots on the tumor. Sometimes it's associated with the serous detachment. The fluorescein angiography is typically show filling of the tumor with the leaking inside the tumor at the late phase. However, the ICG is very important to diagnose the hemangioma. And as this slide shows, it's originated from the short ciliary vessels, and you see the anastomosis between the arteries. And usually it is leak within the tumor, and the most important thing is the washout phenomena, which is really pathognomonic for choroidal hemangioma, in which you have the dye cleared from the tumor at the late phase. B-scan can show a dome, solid shape tumor, and A-scan can show high internal reflectivity. This corresponding to this tumor. This patient has choroidal hemangioma with overlying serous detachment, and this is manifested also by the OCT. The OCT, usually the hemangioma, you can see the tumor pinching or protrude the pigment epithelial layer. However, you cannot identify because the characteristic of the tumor is the same as other choroidal tissue. And there is a fluid because there is a certain detachment. Differential diagnosis of choroidal hemangioma, like choroidal nevus, amelotic choroidal melanoma, choroidal metastasis, and choroidal osteoma. CSR, as I highlight, because sometimes I'm receiving cases, is the diagnosis of CSR, but it turned by choroidal hemangioma, depend on the clinical examination, ICG, as I show you with the washout phenomena, and also by the OCT. The treatment, the mainstay of the treatment, the PDT, and usually have a beautiful result. Transpupillary therapy was proposed. Laser photocoagulation, you have, of course, to avoid it if the location is subfoveal. Radiation in terms of external beam radiation or brachytherapy, this is used if you have extensive retinal detachment. And anti-VEGF injection also shows some promising result. So by this, we finished the choroidal hemangioma. We will go now to the last topic, which is hereditary choroidal disease. The term choroidal dystrophy nowadays, we regard it as a misnomer. Why? Because a current evidence showed the genetic mutation that affect the RPE can lead to atrophic changing in both RPE and choriocapillaries. And most of the genes responsible for the RPE function cause choroidal disease. So it is really a misnomer. It is RPE rather than choroidal. But still we are using as choroidal disease because usually the manifestation in the choroid more than in retina. So in order to understand it, we classify it according to the geographic distribution. In choroidal atrophy phenotype, like in central areolar choroidal dystrophy, like in pre-papillary choroidal dystrophy, and in diffuse choroidal dystrophy. The other one is guided atrophy, and the third one is choroideremia. So let's start with the choroidal atrophy phenotype, starting with the central areolar choroidal dystrophy. It is autosomal dominant and mutation in perforin 2. It is autosomal, sometimes you have autosomal recessive variant. The onset usually between 20 to 40 years of age. Visual acuity typically stabilized and at level of 20/200. Choroidal neovascularization is rarely developed. Usually the ERG normal. You have to differentiate it from Stargardt disease, cone dystrophy, North Carolina dystrophy, and pattern dystrophy, and IMD. At the beginning of the course, you can see like a mottling of the RPE in the macula. And then you can see like a geographic loss of RPE, central location. And you can see the visible large choroidal vessels because of severe RPE and choriocapillaris damage. This lesion, you can see by the autofluorescein, hyperautofluorescein because of the damage of retinal pigment epithelium and subsequent photoreceptors, and you can see also the visible choroidal vessels. And the OCT indication the loss of the RPE choroid and outer nuclear layer. The other one is the pre-papillary choroidal dystrophy. It is autosomal recessive. Sometimes you have autosomal dominant, but it is really rare. And the characteristic atrophy of the RPE and choriocapillary starting around the optic disc. And it's protrude like a finger-like projection. And sometimes this form converts to the diffuse pattern of dystrophy. Usually the ERG normal, and differential diagnosis important to exclude serpiginous choroiditis, pre-papillary pigment epithelial dystrophy. The third choroidal dystrophy phenotype is diffuse choroidal dystrophy. It is autosomal dominant triad, the onset in the 4th and 5th. They present with a poor central vision and impairment of night vision. Visual field show peripheral constriction, ERG subnormal to undetectable, and differential diagnosis you have to exclude systemic toxicity from the thiodiazide, advanced stages of Stargardt pattern and Kinsale Syndrome. And you can see this slide show diffuse RPE and choriocapillaris and visible major choroidal vessels. Guided atrophy. Guided atrophy is autosomal recessive dystrophy, and this is caused by mutation in the gene of ornithine aminotransferase, which is located on chromosome 10. And it's characterized by a high level of ornithine in the plasma. Ornithine can cause, it is toxic and can cause damage of retinal pigment epithelium and choroid and subsequent photoreceptor loss. Patients present in 10th decade of life and present with night blindness, later progressive loss of visual field and visual acuity. The ERG show mild in the early stages, but then become flat in the later stages. The EOG also can reduce. And this can be treated, some patients respond to arginine-restricted diet. So this slide, you can see like a Piven stone atrophy, which coalesce and form like a scallop lesion. And you can see the border of severe RPE choriocapillaris atrophy with the normal retina. Sometimes these patients have also cystoid macular edema, and you have to pay attention for the treatment. The third one is choroideremia. It's X-linked recessive. The genetic mutation in CHM localized in the long arm of X chromosome, XQ21, and it was found that the CHM protein is involved in the removal of the outer segments, disc membranes, by the RPE. So the basic defect is in the RPE, but it causes choroidal manifestation. The onset is usually early in the first and second decade. Night vision and peripheral visual field loss is common. Central vision usually preserved and affected in the later stage of the disease. The peripheral visual field show ring scotoma. Fluorescein angiography and autofluorescein show characteristic because you can appreciate the hyperfluorescein, which is corresponding to the normal visible choriocapillaris, with the hyperfluorescein, which is corresponding to the loss of choriocapillaris. ERG range between abnormal to indistinguished in the midlife, and you have to differentiate it from gyrate atrophy, thiazidine hydrochloride retinal toxicity, and petite crystalline dystrophy. Gene therapy nowadays with the study show a promising effect for this disease entity. So usually, as you can see, it show like a scalloped area of retinal pigment epithelium and choroid, and end with the diffuse choroidal atrophy. And usually you see this reflexes because there is no retina, no choroid, and the reflection is from the sclera. And also it's important to examine the carrier of this disease because usually they show subretinal bag mottling pigments as demonstrated in this slide, and they have also normal ERG. So in general, for choroidal dystrophy, I just list this one, the differential diagnosis, in which if you see any choroidal lesion, you have to don't rush to choroidal dystrophy and put in your mind the retinal dystrophy that I mentioned in the previous lecture. So think about X-linked retinitis pigmentosa, Kinsale Syndrome, petite crystalline dystrophy, thiazidine, retinal toxicity, Stargardt disease, and pattern macular dystrophy. For example, this patient has X-linked retinitis pigmentosa, and you can see the severe choriocapillary and RPE loss with pigment clumps. It's not typical for retinitis pigmentosa, and it's misleading. Looks like a choroidal dystrophy. And you can see the fluorescein angiography, how it's prominent, the hyperfluorescence corresponding to the visible major choroidal vessels and loss of the RPE choriocapillaries that causing the hypofluorescence. Kinsale syndrome, if you remember, this is characterized by retinitis pigmentosa picture in form of pigmentary changing associated with the external ophthalmoplegia, ptosis, cardiac conduction block, cerebral ataxia, or CSF fluid, which is high, more than 100 milligram. And this is the earliest stage of the Kinsale. You can see the pigmentary changing all over the fundus, mainly in the mid-periphery. However, in the later stage, you can see diffuse chorioretinal atrophy. Looks like a diffuse type of choroidal dystrophy. Another differential diagnosis is thiazidine retinal toxicity. And if you can see, it's behaved like a gyrate atrophy. It's characterized by geographic scalloped region of hypopigmentation and loss of RPE with pigment club. So if you see this picture, you will say this is choroideremia or gyrate atrophy, but put also on different diagnosis of thiodazide. In advanced stage of disease, and I'm seeing this also in my practice, advanced stage of Stargardt disease can produce similar picture of diffuse choroidal dystrophy. So also think about end-stage choroidal disease for Stargardt's. So to conclude our topic about choroidal dystrophy, till now there is no definite treatment for hereditary choroidal dystrophy. As for retinal dystrophy, we recommend for periodic ophthalmic examination to monitor progression. Genetic counseling. Counseling is very, very important because till now we don't have any treatment for such disease entity other than the genetic counseling and just educate the parents to avoid the consanguinity and intrafamiliar marriage. And as in retinal dystrophy, you can recommend for glasses, for ultraviolet and short wavelength blue blocking sunglasses, probably to have some protective role against the light exposure. If you feel it needs low vision service, you can refer to the low vision services. Cataract surgery is sometimes recommended because usually they manifest as over the cataract. Cystoid macular edema, as I mentioned previously in the previous lecture, you can use carbon anhydrate inhibitor or steroid. Gene therapy, this is a promising therapy that hope we will find it to treat our patients. Thank you very much. Any question? No question? So either you are not understand or you sleep. Okay, thank you.
بعد بس حط لك هنا اكسر
بسم الله الرحمن الرحيم. السلام عليكم. I am Dr. Anoud Saati from Military Hospital, Anterior Segment Division. I'm glad to start our first academic session for this year in 2017-18 to be organized by Military Hospital. Today we will be having a very special anterior segment topic covered by Dr. Abdul Malik Al-Gahtani, Consultant Anterior Segment Cornea and Refractive Surgery at Prince Sultan Military Medical City. I'm sure that every anterior segment surgeon will be interested to hear what this grand round will be about, since we are all interested in refractive surgery, but we focus mainly on the operative and preoperative assessment and surgical plan. He will be touching the post-operative, which we all overlook, unfortunately, and I'm delighted that and sure that we will learn something new from Dr. Gahtani. So it's about pain control after PRK. تفضل دكتور.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good afternoon, everyone. Thank you, Dr. Saati, for this introduction. And it's a great honor to be with you today. I have no financial interest to declare in this presentation. In 1970, a young boy fell off his bike and he injured his cornea with glass fragments. This boy was seen by an ophthalmologist from Russia. His name is Dr. Fedorov. Dr. Fedorov observed that there is foreign body in the cornea, and he has to do multiple radial incision along the cornea to remove this corneal foreign body. After the corneal injury healed, Dr. Fedorov observed that his vision, the boy's vision, is actually better than before the injury. Then he concluded that the radial cuts flattened the cornea and corrected the myopia the patient having. Later on, Fedorov developed radial keratotomy by calculating how to make radial incisions on the anterior surface of the cornea to change its shape. After this incident, the radial keratotomy became popular on correcting the refractive errors. Till 1988, where a 60-year-old lady diagnosed with malignant melanoma asked the scientist if they would like to do an experiment on her eye before it was removed. Therefore, Dr. Margaret McDonald, an American ophthalmologist, performed the first PRK procedure on the woman that year. In 1995, this procedure was approved in the United States. In the following years, PRK was very popular to correct refractive error, but it has many drawbacks: pain, slow visual recovery, and corneal haze. And to overcome these side effects of PRK, two European ophthalmologists, Ionis Balkaris and Borato, developed the Lasik procedure. Lasik procedure involved cut in the stroma, making a flap, ablation the underlying stroma, and replacing the flap. This procedure was approved in 1999 in the United States. So by Lasik, we had less pain, fast visual recovery, and no haze compared to PRK. With time, there is major complication, but rare, started to appear in the literature. Example, risk of ectasia and flap complications. In 2000, Majmador introduced mitomycin C to eliminate the haze after PRK. And after that, Many publications proved the effectiveness of this drug in removing or preventing haze. So one of the drawbacks of PRK was solved, which is corneal haze. So we lived with pain and slow visual recovery. Now, many surgeons favor surface ablation, like PRK, like Lasik, and Lasik. And this preference, in fact, is due to lower risk for post-operative keratectasia and the possibility of greater ablation in thin cornea, especially in cases with higher refractive error. However, the widespread use of PRK is limited by the intense pain, especially in the first 24 hours. It is intense pain, it is not discomfort. Many books describe it like discomfort. It's not discomfort, it is intense pain. Many studies showed that it is 9 out of 10 score of pain, especially in the first few hours. Pain usually begins within 1 hour after PRK, increases during the next 3 to 4 hours, and subsides once the corneal reepithelialization is complete. What is the mechanism of pain in PRK? The cornea is the most densely innervated structure in the body. The concentration of nerve ending is 200 to 300 times greater than that of the skin, and 20 to 30 greater than that of the dental tissue, which explain the extreme sensitivity and pain sensation of the cornea. Corneal surface ablation leaves numerous highly sensitive nerve endings exposed, leading to severe pain and inflammation. All of us know that the cornea is supplied by the long ciliary nerve, which is branch of the nasociliary nerve. Now, when there is any injury to any structure in the body or any cells, this will activate the phospholipase enzyme. Phospholipase will convert phospholipid in cell membrane to arachidonic acid, and arachidonic acid will be converted to prostaglandin by cyclooxygenase enzyme. And this prostaglandin will lead to the pain and inflammation. There are a growing number of studies regarding post-PRK pain relief. I will review with you the main mechanism and approaches to manage post-PRK pain. Topical non-steroidal anti-inflammatory drugs have been shown in a number of studies to help reduce pain after PRK. Oral gabapentin has variable results. Topical anesthetic drops also was studied. Chilling of the cornea directly following surface ablation showed in few studies a positive effect in reducing the pain. And there are few studies regarding the cycloplegic drops. There are several topical ophthalmic non-steroidal anti-inflammatory drug formulation available in the market, including ketorolac eye drops, prophylac, and diclofenac eye drops. And several clinical studies have shown that topical non-steroidal are effective in controlling pain associated with refractive laser vision correction. All topical non-steroidal anti-inflammatory drugs work by eliminating or inhibiting the cyclooxygenase enzyme, therefore inhibiting the prostaglandin and reducing the pain and inflammation. So this is the site of non-steroidal anti-inflammatory drug action. Mohammed Bour and his group evaluated the pre-operative topical diclofenac drops on post-operative pain. In this study, 70 patients having bilateral PRK received 1 drop of diclofenac in one eye and 1 drop of placebo in the fellow eye. Patients in this study reported pain score were clinically and statistically significantly lower in the eye pre-treated with diclofenac than in the fellow eye. Take note that this study only done, the diclofenac done pre-operatively only. Suleiman and his group evaluated the effectiveness of ketorolac eye drops in resolving pain after PRK. Their study compromised 313 patients having unilateral BRK, 156 patients or eyes have ketorolac eye drops, and 157 placebo. They found patients who received ketorolac eye drops 4 times a day for up to 4 days after surgery reported significantly greater pain relief than control. It's written in the textbook and some paper that bromifenac is 3 to 4 times more potent than other non-steroidal anti-inflammatory drugs. So this study compared bromifenac and ketorolac in pain improving after BRK. This study included 212 eyes, 105 received bromifenac 2 times a day, and 107 received ketorolac 4 times a day. No significant difference were observed between the use of the 2 medications. The only benefit of bromifenac is only used 2 times a day instead of 4 times a day. This is a very interesting study. Islambour and his group evaluated the use of extended release oral diclofenac. Oral diclofenac, sometimes they call it sustained release diclofenac. It has the benefit of keeping the therapeutic level in the blood for longer time, 24 hours. Usually this medication taken once a day instead of 2 or 3 times. Among the 62 patients enrolled in this study, 33 patients were given extended release diclofenac preoperative and postoperative, and 29 patients were given acetaminophen and ibuprofen. So 2 groups, one group diclofenac extended release and the other group acetaminophen with ibuprofen. Patients were examined 2 days after the BRK. The pain score was reduced in the diclofenac group compared to the other group. Topical dilute and full-strength anesthetic solution have also been shown to assist in reduction of pain following BRK, but they can disrupt corneal epithelial cell motility. It can cause many side effects, melting, and also can be toxic to the keratocytes. Factor-Rich and his group studied the effect of topical 0.5 morphine. He has 20 patients received 0.5 morphine and 20 patients received placebo. And they concluded that both average and maximum pain score were lower in the morphine group compared to the placebo group. Oral gabapentin. Gabapentin is medication initially marketed as anticonvulsant medication. Later on, it has been shown to be effective in reducing pain related to various types of neuropathic pain and post-herpetic neuralgia. In the recent year, gabapentin has received attention as analgesics for a wide variety of non-ophthalmic surgical procedures. Few published studies using gabapentin as systemic analgesics drug to control PRK pain, and they showed variable results. Lechinger and his group performed respective randomized double-blind placebo-controlled study included 40 patients. 20 patients received gabapentin 300 milligram and 20 patients received placebo capsule. Gabapentin in this study showed reduction in the pain post-operative, post-PRK compared to the placebo group. Another study by Matthew and his group did randomized mass clinical trial. 42 patients received gabapentin 300 milligrams and 41 received placebo 3 times daily for 7 days. In this study, the gabapentin offered no benefit over placebo in controlling PRK. What about the cold BSS use in post-PRK? Many surgeons applied chilled BSS after ablation and recommend the use of cold artificial tears. And it is believed that cold BSS provide analgesia by blocking impulse conduction through the nerve fibers. From Japan, Kitsuwa and his group evaluated the effect of cooling on pain and corneal haze. So 2-parameter pain and corneal haze. So the corneal surface was cooled before, during, and after laser ablation. 38 highly myopic patients of 38 patients were randomized into 2 groups, 16 eyes with conventional BRK and 20 eyes with cooling BRK. 1 day post-operatively, the patient in the cooling BRK group had significantly less pain. In addition to that, at 3 months, the haze score in the cooling PRK group was significantly less than in the conventional PRK group. We conducted the study at Prince Sultan Medical Military City to evaluate the effect of cold balanced salt solution on pain control in patients having bilateral PRK. Contributors of this study, Dr. Hafid Al-Falih, Anoud Saati, and Ahmed Husni, all from Department of Ophthalmology, Prince Sultan Medical Military City. It was prospective, randomized, controlled patient mass trial. 1 eye of the patient having bilateral PRK was irrigated with cold BSS after the procedure, and the fellow eye was irrigated with regular BSS. All patients underwent ablation using NIDIC EC5000 CX2 excimer laser. Inclusion criteria included age group 20 to 35, no previous ocular surgeries, no previous ocular diseases, same intraoperative and post-operative medication, same deepithelialized area, bandage contact lens was applied until complete epithelial healing. After the procedure, each patient was given numerical pain rating scale, where 0, no pain, and 10, the worst pain possible. And each patient asked to record the pain at 3, 12, 24, 36, 48, and 60 hours. So we got 50 patients, 100 eyes with myopia and or astigmatism enrolled in this study. 2 patients were excluded due to lack of proper pain record documentation. At 3 hours, the difference between the 2 groups was not significant. At 12, 24, 36, the difference between the 2 groups were statistically significant. And the cold group was less than the regular group. While in 48, 60 hours and 72 hours, no difference between the 2 groups. This is the line graph. We can observe here that almost all the patients recorded 9 out of 10 score in the first 3 hours, which indicate severity of pain. What about cycloplegic drops? We all learned that cycloplegic drops is helpful in cases of corneal abrasion to reduce the pain and relieve the ciliary spasm. But this is an interesting study done in emergency department in Australia to compare pain following mechanical corneal abrasion between patients receiving either 5% homatropine or placebo. These patients, all of them came due to corneal abrasion to the emergency room. A blind randomized controlled trial was conducted on 40 adult patients who were randomized to receive either 6-hourly 5% homatropine or placebo. Pain rating were evaluated on many times, and the conclusion of this study, there were no significant difference in pain rating at any time point between those in the homatropine and placebo. Agdam and his group compare the effect of homatropine and diclofenac drops for reducing pain after PRK. This study included 32 patients who underwent bilateral PRK. After the operation, patients received homatropine eye drops in one eye and diclofenac in the fellow eye for 48 hours. Then the pain was evaluated. They concluded that the effect of hematropine seems to be lower compared to diclofenac for reducing pain after PRK. We conducted another study at Prince Sultan Medical Military City to evaluate the effect of cyclopentolate eye drops on pain relief after PRK. Contributors, Rashad Imam, Amal Jaloud. So it was prospective randomized patient mask study. After operation, patient received single drop of cyclopentolate 1% in one eye and no cyclopentolate in the other eye. All patients underwent ablation using NIDIC EC5000 or Wavelight AX5000. Inclusion criteria included no previous ocular surgery, no previous ocular diseases, same intraoperative and post-operative medication, same deepithelialized area, bandage contact lens until complete epithelial healing. 43 patients, 86 eyes with myopia and or myopic astigmatism were enrolled in this study. 19 patients were excluded from the study due to poor compliance with post-operative medication, lack of proper pain record documentation, or alcohol leak during PRK. So we got 24 patients included, age group 25 to 47 years, 33 male and 66 female. Each patient was given the numerical pain rating scale, again, where 0, no pain, and 10, the worst pain possible. And each patient was asked to evaluate the pain at these occasions. Results showed no difference between the two groups on all the occasions. In our study, single cyclopentolate, one drop, single drop, does not seem to have pain relief effect compared with the fellow eye. But this study has its limitations. Single drops was used only, and small sample size. In conclusion, different methods have been studied to promote pain relief after PRK. No methods of pain control is ideal or universally accepted. Topical non-steroidal anti-inflammatory drugs have good evidence in reduced pain after PRK. Oral gabapentin has been studied, but it shows conflicting result. Topical anesthetic drops showed positive result, but it has its own side effect. Cold BSS can be used safely with better pain relief after PRK, but more research is required to be done in this field. Limited publication regarding effect of cycloplegic drops in pain, and these studies showed no effect on pain relief. Thank you very much.
Thank you very much, Dr. Gahtani. Very well, nice coverage of the topic. This is a very, very important topic, actually. We all overlook it. دكتورة ممكن تطفي الجوال جنبك معلش. Yeah, we all overlook it, and unfortunately it is so vital for the patient satisfaction post-op that the patient will have to come back to you or send other patients to you if they feel good. On every day when I do my Lasik session, some patient will tell me, دكتورة هذا الليزر الحار ولا البارد? Am I going to have pain or no pain post-op? And it is a challenging question because pain threshold differs from one patient to another. Let me just highlight one point I figured out, and this is for our colleague residents who see the patients in the emergency room, that it is not uncommon that a patient might come to you in the emergency complaining of severe pain. This would either be related to a lack of understanding of how to use the eye drops or the painkillers or when to use them. Quite a few of them would like to use it on the second day. They don't know that they have to use it on the first day. Some of them have their contact lens fall off and they didn't notice it. And a good number of them might have the contact lens placed upside down. So if you receive a patient that comes to the emergency room post-PRK, just remove this contact lens, do some irrigation, and repeat it. Any questions for Dr. Gahtani from the audience? تفضل دكتور صالح العمر. أنا ماني شايفة اللي ورا. دكتور سعيد.
بسم الله الرحمن الرحيم. Thank you very much, Dr. Abdul Malik. Very nice, well-illustrated lecture. Now, I would like also to echo what Dr. Al-Anud has said about the inverted contact lens. And the trick is that the patient will come to you and he said one eye is bothering him, the other eye is quite well. But also, I would like to inform my colleague that the pain, as said by Dr. Kahtan, it is not discomfort, it is a real pain. I faced this with 3 years ago when I did the Lasik for my daughter. That night, it disturbed me. She disturbed me a lot. I knew that this will happen. I took a binoxonate drops with me. And then, yes, at around 11 or 12 o'clock, I put, and she slept for 3-4 hours, and then she came again. She said, please put these drops. Now, in fact, my routine is to irrigate for a minute with chilled PSS at the conclusion of surgery. And in fact, some of the patients, they come the next day as if it is LASIK rather than surface ablation. They don't feel it. And this is now the situation that this is really, pain is more of a psychological thing. I prepare my patients telling them that this is not unusual to have severe pain. So this is part of the deal. And I think we should inform them as well. Now, why not to prevent this procedure causing pain? Why we are shying away from LASIK? You said the 3 problems, but now also the flap complications with the FEM to LASIK, almost nil, almost. But now we are remaining of the ectasia, and also we have seen ectasia after PRK as well. So why we are hiding and shying of the LASIK procedures?
Well, I agree with you, FEM to LASIK, but not LASIK, not the traditional LASIK. The last time I did LASIK, maybe LASIK with microkeratome 8 years ago. And that time I was at eye hospital in Dahran. They invited me there as a locum and to start their unit, LASIK unit there. And the patient came to me, she's VIB patient, and I was very happy to start the first case. I did the microkeratome, then back. I found the flap is torn from 12 to 6. And it was a shock for me, really. I examined the knife, I examined the blade of the microkeratome, I examined the microtome itself. I reported to the company, but till now I didn't know the reason. That time it was the last case for me, because I don't know, is it phobia or not, I'm not sure. But with FEM to LASIK, yeah, I agree with you, it is encouraging to do it. But you have to have a machine which costs 3 million real. Not every institution can afford it. It's cost for the patient. For me, it's the time of the procedure is longer than BRK. So this is my opinion. Dr. Saati, if you...
I totally agree, and we know that we have the risk of ectasia in our society is very high, especially these young patients who present to you going for military. As we're working, they go for military at a very young age. We know that they are going to progress at one stage, and we know that there is this risk of ectasia. So I prefer myself certainly to do PRK or surface treatment. If in case this patient had a future progression that his refraction was not yet stable, we usually don't do operation. But some patients going for military, we are obliged to do this because it's their future career. So I tell them that I'm going to do your PRK because this is something I can do an enhancement after a few years if in case you had a drop of vision, 1 or 2 diopters. With LASIK, I will not be so confident or comfortable to do this or to offer the patient a refractive surgery.
One point. Now you said that also one advantage of surface treatment that we can go higher myopic situations. Now, do you limit yourself to how high is this before going even not corneal, maybe ICL or others?
Well, my limit is I reserve FEM to LASIK for hyperopic patient. I believe that FEM to LASIK is the result with hyperopic is better than PRK. I forgot the question.
What's your upper limit?
My limit. Upper limit is 8. Above 8, I will start thinking about
Regardless
IC.
of the K reading.
Regardless of the K reading, yes. My upper limit is around 8.5.
Thank you, Abdul Malik. Very nice presentation. I have comments and questions. I agree with Prof. Saleh regarding the pain post-PRK or laser surface ablation. When the patient comes to you in the second day complaining of severe pain, try to just exchange the bandage contact lens. It helps a lot in these patients. They will feel much more comfortable after that. The second thing regarding the femtoLASIK, I think in our society, laser surface ablation is much better than femtoLASIK for two reasons. The incidence of keratoconus is much higher in our society. This is one thing. The second thing, the incidence of dryness is very high. This is apart from the flap complications. My question, did you come across about the difference between different machines, platforms regarding the pain? I mean, NIDIC, Wavelight, Vizix. Is it different? Did you come across about this?
I didn't see anything in this regard to compare different platform or machines.
What about the different types of laser surface ablation, PRK, epilaser?
Well, it's the result in this field is variable. Some studies said that Lasik, which is mechanical removal of epithelium, apply the resin, then replace the epithelial layer. Some studies showed it's better pain with it, and some studies showed the pain is worse with it. So it's not clear whether better pain or worse pain. But how to know, Dr. Saleh, how to know, or Dr. Khalid might help us, how to know that the contact lens is inverted before removing it? Patient came to you and complained of pain. Maybe the contact lens inverted, but I don't know clinically. So how to know? Is there any hint? The microphone عندك.
When it's on the eye. هو بيقول لك وهي على العين. When it's on the patient's eye.
The patient is wearing.
I think the contact lens will be stable if it is right.
Yes.
If it is inverted, it will move a lot when the patient blinks.
Yeah, it is the mobility actually, and the patient will always come and tell you, I don't know where the contact lens, I think it's under my lid.
Some of them,
دكتور سعيد الطواح.
no, some of them are in place, but it is inverted.
تتحرك معاه كثير.
Now I think if it is unilateral, I always blame the lens and change. Now I tend to agree with Dr. Haf that if the patient comes complaining, go and change. I think this is the best.
Thank you.
But now also the dryness matter. I think there are studies show that comparing dryness after surface to Lasik, and there is no difference between the two. So I think both any laser surgery, corneal surgery, it has the bad thing about dryness, even because the nerves are also on the superior stroma as well.
I would like to stress on the dryness. Actually, I found almost 30% of my patients who comes for refractive surgery, they have at least a mild to moderate dryness.
To start with.
Yeah.
Can we give بعد إذنك دكتور سمير دكتور سعيد من أول مستني ثواني. تفضل دكتور سعيد.
Thank you, Dr. Abdul Malik, for excellent, informative presentation. Actually, when we go back, do you hear me?
Yes, very well.
When you go back, when we started BRK, patient was presenting to the emergency room crying of pain. Mm-hmm. Then it has, when we want to prevent all this, it starts from the surgery, from the OR. Just immediately wash the cornea. This will call the effect of the burning effect, okay? And this will call it down. So this is number one. Second, usually when you put contact lens with dry, it will stick to the surface of the cornea. And this is an important role to increase the pain. So from OR, just only wash it thoroughly, call the effect of the laser, and it will help for the contact lens to be moving over the surface rather than sticking, adhering to the surface, okay? And this is what we see it with the patient with having Lasik and the crying of pain, regardless what you give them most of the time. So this is one thing. The other things, when we started Diclofenac long back, all patients were happy, okay? And what I'm doing, the first hour, I give it every 15 minutes. So 4 times in the first hour. Then I just only use it for 3 days only, QID. So this is, when you started 15 minutes in the first hour, it will kill all the pain. And
like a loading dose?
Yes,
okay.
Like a loading dose, okay? And make sure to instruct patient for having the drops every 1 hour, because this will smoothen the movement of the contact lens, because this is most of it related to the contact lens adherent. I never use, and I don't like to use cycloplegic. Why? Because it will make the vision, disturb the vision, and make patient worry about his future. So Diclofenac will do all the job with contact lens and lubrication. This is regarding the pain. So most of my patients, I used to ask them, even they never complain of pain if I'm using this, and this is my protocol for post-PRK patient. Regarding Dr. Saleh, I do agree with him. There's still role for LASIK, for femtosecond, for it's a matter of just only how much you will leave a non-touched cornea, and this is important. Regarding the key reading, I do respect key reading. I never exceed 45. If there is high astigmatism, also 1.5 and more, I'll pay attention for that. So because our society, we have dryness, and most of the patient, even with using the now mobile, and the dryness is getting severer and severer, even for young patient. And most of our patient, the problem is rubbing the eye, and this is the cause. It's not because you always have, I'm sure, any refractive surgeon, he will leave at least non-touch 300 micron. But the problem, if you are keeping rubbing the eye, and this is those fellows or residents working with me, I always instruct patient, try to avoid this as much as he can. So this is important regarding the pain. Regarding 8 diopter nowadays, you even might go more than that with the BRK. It depends on the your topography finding and all the things related. But it's always better to be 8 diopter and less to avoid the complication. More than 8, we might shift to ICL, and this is important. Thank you very much.
Thank you, Dr. Mutawwa. تفضل Dr. Samir.
Thank you, Dr. Malik, for this nice lecture. Actually, I have a comment and then one question. The comment is part of the management or part of controlling the pain, keeping the patient in the picture. So you have to have good communication. So you tell him this procedure causes a superficial injury and you'll expect some pain till the surface heals. So if he's aware of what may happen, he'll not be shocked by the pain and he will expect it, and we stand for it. My question is, did anyone evaluate paracetamol effect post-LASIK?
Well, as a study, no, but clinical practice, it is not effective unless you add the non-steroidal with it, or you use the one with codeine.
What is your routine post-PRK?
My routine from first day, prednisolone acetate 1%, moxifloxacin, Macular. Also, before I was using Diclofenac with Voltaren, which is potent anti-inflammatory, but it's not. It's not available in the market anymore. I give Solbadine, which is paracetamol with codeine, and I give the patient only 1 minute of topical anesthesia to use it PRN. It contains only 6 or 7 drops. Cold BSS, of course, after each surgery. Before the surgery, yes, this is important. Before the surgery, In the morning, I give the patient 1 drop of non-steroidal, Macular or whatever, and alpha-GAN to reduce the congestion post-op. And I believe the congestion is some part of the discomfort due to congestion. So patient came out of the OR with white eyes. Dr. Samar?
Thank you, Dr. Kahtani, for this presentation. Yeah, I just want to be directed to the topic. One thing about the non-steroidals, it was mentioned this year in the academy that people needs to be really very cautious in using the non-steroidals. You highlighted that one. The articles they mentioned needs to be, used for 4 days. The reason behind, with the growing, cross-linking worldwide, people, they just copy-paste whatever they're using in a BRK as post-op management for pain and everything to the cross-linking. Randleman and others, they reported the corneal melting after cross-linking. So now in the academy, people are always talking that it's absolute contraindication to use non-steroidal following cross-linking because of the melt association with the procedure itself, inflammation. And the other thing also, if you're using it for post-Lasik ectasia, then you will start to see some melt at the edges of the flap. So that's one point. So the same thing will be, I think, applicable for our society. But for the BRK, I agree with you. It's like the 4 days. I'm using it like you, only just for a short period. But the concern, you touch very nice what are the causes of the pain. The differences in the removing the epithelium between surgeons and surgeons play a role. So what's your favorite one? And I have one comment about this one, please.
Removal of epithelium for me with alcohol. And I remove it completely. I didn't replace it. Dr. Saati, I guess he's scraping.
I was a fan of corneal scraping it with a blade rather than using alcohol, in the form that I don't like to use too many chemicals on the eye, mitomycin and the burn and the alcohol. And I was doing quite well because I also thought that when I use alcohol, I find when I remove the contact lens on the first follow-up, I can see that the epithelium is a little bit loose and it's not as firm as I want it to be, and this causes like redundant tissue and severe pain. So I thought this was related to the alcohol. That's why I didn't use alcohol for a very long time, and I only used manual scraping. But then, again, some patient would come with this loose, redundant epithelium under the contact lens. So I guess I was wrong. It's not related to the alcohol. So right now I'm back to alcohol, but I put it on a sponge. I don't put it on the well. So it's very controlled.
Okay.
Dr. Samar, regarding the non-steroidal warning, is this something new or the old warning a few years ago?
No, this year.
This year.
Yes, it was mentioned, this year, that don't use it, Randleman and his group even.
Which type of non-steroidal? Which one? Do you remember?
I don't recall whether it was diclofenac or nifenac. I'm not sure which one of these two it could be. Oh, Prophylactic or diclofenac. The reason behind what I'm saying is that there was a group who were trying to promote a new procedure. They call it EP-Bowman keratectomy. Like 3 years ago, and it was started in Tel Aviv in Israel, whereby they invented an instrument. They're trying to remove the epithelium. It's a small instrument, it's a tiny one. You will be able to remove the epithelium in the basement in a smoother fashion. They believe that the smoother the removal of the epithelium, the less pain the patient will have. So it's like a small blade, but with the geometry closer to the eye. So you just move it forward in the cornea, and it will remove it all as one layer to you. And then you won't have any redundant epithelial tags or anything underneath, so the ablation even will be smoother. So they claim this one, and then the Americans, they took over, and this year at the academy, they promoted it very well, the EP-Bowman keratectomy. So they believe, with their comparative study, a group of India, that the pain is much less in comparison to the excuse me, to the mechanical blade. But I agree with you that alcohol, I was like Doctora, hesitant. Excuse me, hesitant to use it in the past because combining too much mitomycin and alcohol, and then mechanical, I'm back again now to the alcohol, because at least you need to get the smoothest for your ablation profile as well as for the pain. That's it.
And easier for training the residents. So it kills the nerve endings, numbs the nerve ending. Maybe. تفضل دكتورة. تفضل.
So regarding the non-steroid anti-inflammatory medication use, apart from the melting and the reported cases of even perforation after PRK, there is also the prolonged healing of the corneal epithelial defect that can result in haze and scarring. So we should consider this in consideration. The second point is the new platform laser machines is heating the cornea to a very minimal temperature, reaching at a maximum to 4 Celsius degree only. So what is the role of the cooling the basis if this is the condition? I'm not sure about with the NIDIC, but with the with the Schwint, yes, since you name it, yes. So it's 4 and it's published for that, and it was measured. So if it is only 4, so there is no rule for the cooling. Maybe the effect of the basis washing the cytokines, the inflammatory cytokines, but not the cooling effect per se.
See, I use something called, but not the chilled BSS. I ask the patients at home if they have pain to use ice packs on their eyes. And this really is effective as a pain relieving, and in the same time you don't put anything on the eye. Just use cold ice packs. I think that the temporary effect of the chill or the ice reduces makes vasoconstriction and reduces the chemical cascade of pain. For the temporary effect on the eye, that I'm not sure what is the mechanical effect of it, but for sure if you have any cold object like your hand or your bottle or ice pack on a painful eye, it will reduce this severe post-op pain from PRK.
Cold basis, even cold water, even in other diseases reported to reduce the pain. But whether it is irrigation or the cooling effect, it is not clear, even if with my revision to the literature about this issue. But if you say irrigation only, there are many studies, not many studies, few studies compared irrigation with cold and irrigation with regular BSS, and the cold BSS showed better result with compared to the regular one.
But again, most of these studies is a very small numbers.
Yeah,
so I will not depend totally, yes, because it is again, it depends on the pain threshold of the patient.
Yes, and old machine, as you mentioned.
Anyhow, at the end, you cannot cool it without irrigating it. Victoria. The microphone.
Same question about using a cold BSS. You just showed us 2 studies, one by the Japanese team and the other one by your team. And the one by Japanese showed that there was a significant difference between the chilled or the cold BSS and the regular one, while yours showed no significant difference.
No, it showed significant. Our study showed significant difference between them.
I think yeah.
But not the 3 hours after that.
So it is comparable, the 2 studies are comparable?
Yeah, it's the same conclusion. Maybe you are talking about the cyclobentonate. The cyclobentonate study didn't show difference, but the cold BSS study showed difference between the 2 groups.
Okay, can you enlighten us more about how frequent or what's the duration of putting cold BSS
well, usually,
post-operatively?
Myself, I ask the assistant or nurse to keep it in the freezer. Sometimes you find difficulty if she take it directly from the freezer to the eye, you can, because it's freezing. So I will ask her to take it out maybe 1 hour or 30 minutes before the procedure. Then I will apply the irrigation for 30 seconds. By the way, it is painful. To apply the cold or chilled BSS, it is painful to the eye. So, but you have to tell the patient this is very cold solution to relieve the pain. So minimum for me 30 seconds minimum.
And post-operatively?
Post-operatively, I don't use the chilled BSS. Only
No, I mean
immediate
you instruct the patient to put his drops in the fridge and use a cold drop. So how frequently should use the BSS?
In the summer, usually I ask all the patient to keep their medication in the fridge, especially the artificial tears.
I mean, if there is any effect on using frequent cold lubricants on the pain, post-operatively?
Maybe it will have the same positive effect, but I have no study to present it.
Thank you.
Any more questions? تفضل دكتور.
Like what? No, I didn't come across this. I didn't come across this study. Maybe not. Gabapentin is only a few studies, and I don't think ophthalmologists will use it because they are not familiar with this drug. Focus on non-steroidal, oral, and topical. This is. They have very strong evidence in the literature, with the precaution as the colleagues mentioned. One important point, I asked one of the pain physician. He said one of the mistakes the physician doing for analgesics that they give the tablets, for example, paracetamol, PRN. He asked me not to give it PRN, give it regular for 3 days. Don't wait the pain to happen, then start the medication. It will work. It will stay 2 hours till it be effective. So make it regular in the first 3 days, then PRN.
So regarding the oral tablets, so is Rifacode available in the market?
What is it?
Rifacode.
Yes.
My understanding is like a narcotic.
Rifacode, no.
So in the private, what do you give? As I said,
in the private, I give Solbadine.
Solbadine.
Yes, I give non-steroidal topical drops for 4 days or 3 days. Pre-operative 1 drops pre-operative non-steroidal and Alphagan, Prid 40 and Vigamox.
Okay. Because
and 1 minims.
1 minims mean
yeah,
lubricants.
This is important as well. Yeah, 1 minims as well.
Okay, so here in KKESH, because we don't have Solbadine, we have Rifacode, and the codeine concentration is higher in comparison to the Solbadine.
Do you remember what's the concentration?
How many milligram? I think it's the double. The Rifacode has double codeine in comparison to Solbadine. So the reason, yeah.
What is it?
10. But Solbadine is less. So the I actually stopped prescribing the Rifacode. It's a control medication. Yeah. The reason behind is that I got a few patients addict to that medication. So some of the people who, like resident fellows who were rotating, during my eczema laser session were extremely generous. And instead of prescribing it to the first 2 or 3 days, they were giving it to them like 7 days. And in the follow-ups, they keep requesting it. And then I got some of them really addicted, even fighting in the post-op clinic. So I decided to move on and not to use it. And I've discussed it with the anesthesia because they are the expert in the main management and the medicine. And I came with one solution: just use Lerca. Lerca is, you've shown the gabapentin. That's the it's less in intensity and the side effects and everything, and it's available. It's just 150 BID. So I start to use the Lerca. Is it effective? It is effective. It is effective. So. Yeah, they stopped it. Yeah, they withdraw it, but it has no addict. It has no addict tendency. It makes them a little bit drowsy, but there is no addict tendency toward it. Yeah, so Lerca is, yeah, but at least no addiction for a short period.
يعطيكم العافية. I think we can move on to our next session, the anterior segment quiz for the residents by Dr. Gahtani again. Okay, you have 2 minutes generously from Dr. Gahtani.
ماشي بس سلو مرة سلو. هلا خلاص ديسكس الحين افتر
كويز. نبدأ الكويز. يلا الله يعينكم. فارماكولوجي كويز. ophthalmic فارماكولوجي كويز. Question number 1, what's the scientific name and concentration of the steroid in the following eye drops? Scientific name and concentration of steroid in the following eye drops. هذا شكل بعضها مكتوب فيه. الشباب اللي يساعدون بعض هناك. سؤال رقم 2. What is the concentration of prophylactic intracameral sulfurexime for cataract surgery? B. How to prepare it from 750 milligram powder. طيب أنا بحل لكم A الكونسنتريشن 10 milligram per ml. How to prepare it. السيفركسايم عادة available 750 milligram powder. How to prepare it. How to prepare 10 milligram per ml. واضح السؤال؟ Concentration of intracameral sulfurexime is 10 milligram per ml. The question: how to prepare it from 750 milligram powder. سؤال رقم 3. What are the content of peripalpar anesthesia? أربعة. What is the mechanism of action of non-steroidal anti-inflammatory drug? هذا عاد قلت له في الجراند راوند. خمسة. What is the mechanism of action of these eye drops? واضحة؟ one answer كلها زي بعض. What is the mechanism of action? عندك ترافاتان ولوميجان ولاتانوبروست. Again, what is the scientific name and concentration of the steroid in the following eye drops? How to prepare intracameral sulfurexime from 750 milligram powder? What are the content of peripalpar anesthesia? Mechanism of action? طب تعال هنا قدم. سيفركسايم متى جيت انت؟ طيب نعيد من جديد عشانك. انت لحالك ولا في احد معك؟ لسه بيجوا؟ What is the scientific name and concentration of steroid in the following eye drops? Intracameral sulfurexime concentration is 10 milligram per ml. How to prepare it from 750 powder? Content of local anesthesia. What is the mechanism of action? And what is the mechanism of action? أعطونا الإجابات. شباب الإجابات. سؤال رقم 1. مين جاوب لي إياه؟ إذا بدينا الإجابات هتتوقف استلام الأوراق. سؤال رقم 1. الإجابة. خلاص نبدأ الإجابات. مين يجاوب السؤال رقم 1؟ تفضل. تعال خذ ميكروفون أول. خلاص الأوراق كلها استلمت؟ خلاص؟ أوكي يلا تفضل.
This is prednisolone acetate, 1%, and the left side, which is equal to 10 milligram.
Okay. Which 10 milligram?
10 milligram or 1%?
Incomplete answer. 10 milligram per
ml.
So it is 1% prednisolone acetate equal to 10 milligram per ml. التوبراديكس ليه انا جايبها هذه؟ لانها very commonly used، يعني every day we use it. So we know the concentration. في شيء اسمه بريدنيزولون فوسفات؟ في there is prednisolone phosphate which is weaker than prednisolone acetate and usually available in minims. التوبراديكس شو؟ الدكس التوبراديكس
combination of dexamethasone and tobramycin. The suspension, this one, it has two concentration, either 0.1 or 0.05.
cannot be Tobradix only 0.1 dexamethasone. It should be another name. And we cannot put Tobradix for two concentration with tobramycin. Question number 2. What's your question number 2? طيب. This is a tricky question. What's the importance of intracameral cephalic sign? it has very strong evidence to prevent endophthalmitis post-op. Who is not giving intracameral Fluorescein post-op at the end of surgery? كلكم تحطون؟ ها؟ ريزيدنت. طيب انتوا تسووا كاتاراكت ولا ما تسووا؟ طيب how to prepare it? Do we have commercially available 10 milligram per ml? Do we have? طيب مين اللي بيعلمنا how to prepare it؟ في one company producing Abrocam. It's European company producing this commercially available, ready to inject. لكن most of the time the hospital need to prepare it. تفضل. ميكروفون. مرة ثانية. ميكروفون. وين الميكروفون كان مع زميلك؟ ايوه هناك. ايوه.
We can combine a vial with a 75 ml BSS.
75
ml BSS.
You add it to
this vial, which is 750.
كم حيطلع؟
Then we will take 10 ml. It will be the same concentration.
طيب, who has any other answer? Is this answer correct or no? أنا بحسبها لك الحين. Answer, it is correct but not practical. من وين حتجيب لك 75 سرنج؟ كيف حتجيبها؟ يعني as a mathematics is correct لكنها ما كيف حتسويها؟ تقدر تشرح لي اياها؟ لازم يكون عندك سرنج 75 ولا امبول 75 ستيرايل. يعني the maximum syringe you have it maybe 10, 15 or 20 cc. It's more contamination. And how you will make sure it is 75? طيب. Take 1 cc of normal saline or BSS, inject it inside this ampoule. كم هيطلع لك الكونسنتريشن؟ Sorry, 10 cc. 10 cc normal saline injected inside this one. 75 ملغ per ml. واضح؟ احنا كم نبغى؟ طيب take one from the 75, take 1 cc. Take 1 cc. It contains 75. صح؟ واضح؟ طيب add to it 6.5. Add to it 6.5 normal saline. واضحة ولا مو واضحة؟ رياضيات. أنت الآن عندك 75. If you add 10 cc to this ampoule, it will be 75 milligram per ml. Take 1 cc only. This 1 cc contains 75 milligram per ml. Add to it 6.5. كم حيطلع؟ هيطلع 7.5. Divide the 7. Divide 75 divided by 7.5. مرة ثانية هعيدها. Take 1 cc. ال 1 cc كم فيه؟ 75 ملغ. صح؟ واضح يا شباب؟ واضح؟ من جديد add 10 cc to the powder. Concentration will be 75 milligram per ml. Each ml contains 75 milligram. Take 1 cc of them, add 6.5. كم صار الفوليوم؟ 7.5. Divide 75 concentration divided by 7.5 حيطلع 10 cc per ml. تفضل. في another way طبعا بس انها 75 not practical. تفضل. طيب. مرة ثانية بس خذ الميكروفون لأن ما أسمعك زين.
I think if we add 7.5 cc
7.5 cc كم حتطلع؟
it will be 100 milligram per ml.
خلينا نشوف 7 تقسيم 7.5 طيب تطلع 100 ملغ بير ml. طيب وبعدين؟
Then we aspirate 0.5 and 5 cc
0.5
and 5 cc syringe.
0.5 كم فيها؟
No, I mean 0.5 and 5 cc syringe and the rest is saline. It will be 10 milligram per ml.
طيب ال 0.5 كم فيها اللي سحبتها؟ 50 ملغ. طيب انت ليش ما تحبت 1 سي سي؟
لا 0.5 if you aspirate still 100 milligram per ml.
طيب وتزيد عليها ايش؟
دي 4.5 BSS.
طيب يعني صارت 50 50 divided by 5 correct. This is another way correct. Correct. So the idea here, there is only one company produce this intracranial Circumscribed. So either the pharmacy or you have to prepare it. And don't miss intracranial Circumscribed with each cataract surgery. بريبالبر انستيزيا. تفضلي دكتورة حنان، الأسبوع الماضي أنت محضرتها بنفسك. How many component?
5 cc of lidocaine 2%.
5 cc lidocaine 2%.
5 cc of bupivacaine 0.5%.
Bupivacaine, what's the concentration?
0.5%.
0.5%.
And hyaluronidase 7.5 units.
كم الهيالورونيديز؟
7.5 units per ml.
7.5.
7.5
7.5 ايش؟ 7.5 يونت؟
units per ml.
لا قليلة 7.5 يونت. احنا نبغى اليونت نبغى at least 50 to 300 international unit. But it's accepted answer. يعني lidocaine 2%. 1% can be injected. 1% can be or cannot be. Yes or no?
No, it cannot.
Can be, yes, but the effectiveness will be lower than 2%. Sorry? It is optional, but it is important. If you don't inject Y-days, you will have during surgery positive pressure, and you can observe it. Because Y-days help spreading of the anesthesia and the tissue. Also, it has a synergistic effect as well. So I feel it is important if you have it. Yes, or you need longer time to spread by itself. هي teaching more than quiz ولا كلكم حتاخذوا في المارك. طيب what's the function of non-steroidal? What is it? ماني سامع. cyclooxygenase inhibitor. طيب إذا صار في cyclooxygenase inhibition. prostaglandin inhibition. And inflammation will be less, and pain will be less, and blood vessel dilatation will be less. طيب, what is the action of these drugs? نبغى وجوه ثانية. أيوة تفضل. Prostaglandin analog, okay. Okay, help in UV scleral outflow to reduce the IUB. طيب أنا ليش جبت هذه بروستاجلاندين انتاجونست صح ولا لا؟ وهذه بروستاجلاندين انالوج. طيب ما يعلمنا شيء أو حاجة؟ لا احنا نتكلم عن البروستاجلاندين الان. واحد اجونست واحد انتاجونست. Okay, this is increase inflammation and this one reduce inflammation. في important point you have to know it in cataract surgery. لا ما هي هذه النقطة اللي ابغاها. تفضل. في الكاتاراكت سيرجري نبغاها. تفضل. ما اسمع الميكروفون. ميكروفون. شوف على يمينك.
The antagonist will decrease post-cataract cystoid macular edema.
Okay.
Like Macular.
والagonist?
Agonist may predispose to.
طيب good answer. طبعا لكن it was observed in many studies that patient taking prostaglandin analog like Travatan, latanoprost, that the macular edema more with other patients, because prostaglandin will increase inflammation and will increase the macular edema. So in these cases, it is advisable to stop the prostaglandin analog, replace it with other anti-glaucoma medication, like pyrimidine, like timolol, for a while. Then go back to prostaglandin analog. In addition to that, you have to add to the patient non-steroidal anti-inflammatory drug to block any prostaglandin in the eye before the surgery. Is it clear? شكرا لكم. والله في سؤال ثاني انا ما حطيته وانا ما ادري ليه. اخر سؤال انا حجاوب عنكم. مايتومايسين 0.2 ملغ بير ام ال ايكوال تو ايش؟ A 0.02%. لما لو عندك برسنتج تحول الملي جرام بير ام ال تضربه في 10 والعكس. لما عندك برسنتج بتحوله الملي جرام بير ام ال تضربه في 10. ولذلك البريديسونون 1% لما تحوله يصير 10 ملي جرام بير ام ال. الله يعافيك. شكرا لك.
Well done. يعطيكم العافية. I think you can take like 15 minutes break. إيش رأيكم؟ صلاة و come back for the presentations. We have three interesting cases, very interesting cases, very teaching. إن شاء الله الساعة 4:45.
ما في.
وين المدخل يو اس بي؟ لا 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 ايوه بس
USB واحد.
بسم الله الرحمن الرحيم. توي اكتشف دكتور قحطاني انه هذا شغال ولا كنت ما زعجتك هناك. طيب are we set؟ طيب بسم الله الرحمن الرحيم. We have 3 interesting topics كل واحد أحلى من الثاني. The first case will be presented by دكتورة حنان الشعلان, our second year resident rotating at Military Hospital. She will describe a case that we often overlook, and if you haven't read about it, you will miss it. So تفضلي دكتورة.
بسم الله الرحمن الرحيم. I would like to thank Dr. Anud Saati for his kind supervision. This case is under the name liquefied after cataract. This is an 83-year-old male, diabetic, hypertensive, and asthmatic, who presented first time to oculoplasty clinic complaining of droopy right lower lid since 20 years. He's a known case of congenital ichthyosis, manifested as right lower lid ectropion and scaly skin. His past history was significant for phaco BCIOL-OU done elsewhere 7 years back. He has no other significant past history or systemic history. On examination, his best corrected visual acuity was 20/20 in the right, 20/40 in the left, corrected by pinhole to 20/30. His IOP was within normal limits. This is an external photo of both eyes of the patient, showing right lower lid ectropion and dry scaly skin all over the face. This is the slit lamp photo of the left eye, showing our interesting finding. I will show first another picture of the same finding. So on these 2 pictures, we can see a distension of the posterior capsule associated with a fluid, milky, cloudy fluid between the IOL optic and the posterior capsule. Here we can see the bucket of fluid entrapped between the IOL optic and the posterior capsule, associated also with some element of Elshing pairs. The rest of the examination was within normal limits, including dilated fundus exam. Refraction was done for the patient. It showed plano minus 0.75 axis 30 in the right, plus 1.75 minus 2.75 axis 95 in the left, corrected the vision only to 20/30. AC depth was measured for both eyes, and it shows difference in 2 eyes. Right eye 2.86, while left eye is 2.26 only. This is the anterior segment OCT, confirming the same finding of a bucket of fluid entrapped between the IOL optic and the posterior capsule. So our impression was liquefied after cataract, which is the late type of what is called capsular bag distension syndrome. This condition was first described in the literature by Davidson in 1990. He called it capsular bag distension syndrome, in which he described 6 cases post-phaco BCIOL with the same findings of distended posterior capsule, shallow AC, high IOP at presentation, and unplanned myopic shift post-op. He was followed by David Efrig in 1997, who described the same condition under the name capsulorhexis-related lacteochromantia, in which lacteo means milky and chromen is a small bag in referral to small capsulorhexis, which he thought is the cause of this condition. He aspirated this fluid and he sent it for analysis, and he found that it is consisted of alpha crystalline and albumin, which reinforces his hypothesis that this fluid is from the lens itself and it is not an inflammatory fluid or inflammatory reaction. He was followed by Mikey, who classified the condition according to the time of onset into intra-op, early post-op, and late post-op. He thought that the cause for intra-op and early post-op is a retained capsular viscoelastic material behind the IOL, while the cause for the late post-op, which he called also liquefied after cataract and retrolenticular pseudohypopian, is caused by retained cortical materials from the lens, which also causes osmotic gradient behind and pulls the aqueous humor into this space. This is some photos from the literature showing the same findings of distended capsular bag and pocket of fluid. And this is another image. So this condition is rare in the literature. It was reported to be 3 in every 1,100 cases of cataract extraction. And the early type seems to be much more frequent than the late type. The patient classically is asymptomatic, and it was discovered as incidental finding. It can be discovered years after phaco. The longest time reported was 12 years after phaco. It was associated with a myopic shift attributed to the anterior displacement of the IOL by the accumulated fluid. However, in the new recent report, it was reported to be associated with hyperopic shift, myopic shift, or no change in refraction at all. Treatment options can be surgical or non-surgical. Non-surgical in terms of YAG capsulotomy, it was the most commonly performed in the literature. Surgical can be by aspiration of this fluid, either through anterior chamber approach by cannula or through pars plana approach. Most of the cases reported confirmed the sterility of this fluid by analysis and microbiological studies. However, we have one report showing that this fluid was colonized with B. acnes. They aspirated this fluid through anterior chamber and they sent it for analysis, and they found B. acnes. However, this patient didn't show any signs of inflammation post-op. This is the end of my presentation. Thank you so much.
Thank you, Dr. Shalan. I love your presentation and your happy and sad faces.
Thank you.
Okay, so I remember presenting such a case in our revision for those, and I have to take the credit to Dr. Ahmed Saleh, who picked this patient from the from the oculoplastic clinic and asked me, "Doctor, is this what you told us about in the revision?" And luckily it was. And I also have to mention here the cooperation I see between the residents coming from the program. Dr. Ahmed Saleh was the first to see, but he gave the cases to his colleagues, and that's something that an attitude I'd like to see in between all the residents. Dr. Hanan, you covered the topic very well. The thing I want to focus here is don't wait to have or don't keep your interest to see what kind of refractive error this patient have, because the opacity itself is enough to remove. This difference in the visual acuity in the patient is usually from the cloudiness of behind the IOL. It's causing a media opacity. It will cause a difference in the refractive index, and the patient will have different refractive error. Even if the patient is not complaining, I believe this should be removed, because in the future it can cause glaucoma. With the time, it can cause a collection of fluid more and more and more and more, and it will be even presenting with glaucoma lately. My junior friends here were reluctant to do the YAG PI because they were concerned about the P. acne. P. acne is one case reported, and we know that chronic endophthalmitis can happen even after sterile cataract, حتى لو ما في liquefied after cataract. So this is not related to the process of inflammation اللي موجود الآن. Okay? Any questions? تفضل دكتور. This is developed later. If it was missed, it shouldn't go opaque. يعني لو كان viscoelastic retained, أولاً الvisco we know that it should go after 3 to 5 days maximum, no matter what kind of visco you used. And if it did not go, it will raise the intraocular pressure because it's acute. This was late. It came late. Okay? شكرا دكتورة. إيه. We booked him for YAG cap, but he didn't show up. But this is what we want to do. YAG cap. I have treated like 6 cases before, and it's very easy, very simple. The thing is, when you hit with the YAG, this fluid will start forming a cloud in front of you. So you just need to wait until you see a little more and use your imagination to where you hit your capsule next. يكفي puncture في الوسط or تحت and most of the fluid will go out. تفضل دكتور. None.
Thank you so much.
Okay, the next case is a surprise to me before the Dr. Hanan, before Dr. Rihab al-Rashidi. It showed me when I gave her this case that how much I'm still learning, and what we have. She's going to present 2 cases. What I learned from the first case that helped me manage the second case. تفضلي دكتورة رحاب.
Good afternoon, everyone. I would love to thank Dr. Anoud for helping me through this presentation. As she mentioned, I'm going to present 2 cases with similar post. I'm going to start with case 1. 76 years old male status post primary repair for open globe of the left eye 3 years ago, managed in KKESH here with tectonic keratoplasty, lensectomy, and retinal detachment repair with silicone oil injection, followed by silicone oil removal a few years later. The patient came to Military Hospital with graft failure. He underwent penetrating keratoplasty and had smooth post-op recovery. Few days later, in his follow-up, he presented with vision 20/30 of the right eye, counting finger of the left eye, and IOP 14 millimercury of right eye, and left eye was 12, and the other examination of the right eye was within normal. This is slit lamp photo of the left eye. We can see clear graft, healed epithelium, and good rediflex. Now I'm going to take you through slit beam of the cornea. So concentrate. Any striking finding? You want me to go back again? Yeah, okay. Yes. As we can see here, there is a retrocorneal membrane, a picture of double anterior chamber. What is this membrane? We ask ourselves, what is this membrane? It could be the graft self-deciment detach, or leftover from the previous failed surgery deciment, or it is from the patient deciment. I will answer this question later. Case 2. 71 years old lady with pseudophakic bullous keratopathy was booked for DASIC, the left eye, but BKB was done instead. Post-op had smooth recovery. Few days later, in her follow-up, she presented with vision 20/60 of the right eye, 20/120 of the left eye. IB was 12 for the right eye and 14 for the left eye, and the other exam for the right eye was within normal. This is slit lamp photo of the left eye. As you can see, clear graft, healed epithelium, and good rediflex. Now also I will take you through slit beam of the anterior. Any striking finding? Yes. We have another retrocorneal membrane, another picture of the double anterior chamber. Also we raise the same question, what is this membrane? So, as we can see here, we have a clear graft. So if it was the deciment detachment from the graft, we will have a cloudy graft, but we have here clear graft. So for sure it's not. So after doing investigation, as we can see here, OCT showing a clear graft with shining of the endothelium of the graft, and we can see this retrocorneal membrane attached to the patient own cornea. And its similar finding was for the second patient. So our impression for both cases, double anterior chamber of left eye, which is a leftover of total deciment membrane detachment of patient own cornea. In first patient was post revision of BKB and multiple surgery, and the other case was post BKB. So we ask ourselves, what shall we do? Observation or intervene? And if we're gonna intervene, are we gonna intervene surgically or non-surgically? So observation, I go through literature looking for possibility of observation. But we have to understand one thing. Double anterior chamber, the one happening in deep anterior lamellar keratoblasty, is totally different than what happened in our cases. In these cases, we can wait for spontaneous resolution, as we can see in this article, and the patient will have a good visual outcome. But in our cases, these are post-BKB. So our precious endothelium graft cell are entrapped between this retrocorneal membrane and not in communication with anterior chamber. So we don't want anything to hit this endothelium, so we have to interfere. So decision was made to interfere. So in first case, we decided to take the patient to the OR. And it was very challenging. There was visualization was very difficult. Even the surgeon asked the nurse to hold the portable slit lamp so she can have a coaxial light to see. But it was partially successful, and only 1/3 of the membrane was removed. So since the surgical intervention was not the best way, we're thinking about non-invasive way. So we came through YAG laser. So this cement membrane was ruptured in similar manner to YAG capsulotomy, but the energy was needed was higher, 4.5 microjoule, to have effective laser. So we managed the second case with YAG. Patients were doing well, satisfied about the outcome, and pain-free. Unfortunately, I don't have the picture, but the take-home message here, use all diagnostic tool and investigation needed to have soil diagnosis. As we can see, management can be harmful if we misdiagnose these patients, or if we put like in deep anterior lamellar keratoplasty, managing like with waiting for spontaneous resolution or air bubble, we will damage our graft. And the second message, for patients with severe pseudophakic bullous keratopathy, check for dissement detachment intraoperatively before closure, because it can be missed. Thank you.
Dr. Rehab covered the topic nicely. I missed to give her some images. Just to explain to you what happened in the first case. So this patient came to my clinic and asking for correction for his visual rehabilitation. He had a completely failed graft with even vascularization. I gave him 2 doses of Avastin, and then when the eye was ready, I decided to take him for PKP. Now, I was not sure if he's phakic or aphakic. The B scan was done, and there was this membrane. However, when we did the surgery, I found that he's aphakic, and to be honest, on table, I could see the glistening of something over the pupillary margin. I thought this is maybe remaining silicone oil, because I placed a lot of viscoelastic, perhaps. I continued my procedure normally, and then when I saw the patient post-operatively in the first week, and I figured out that this membrane is there, I panicked. I didn't know what tissue am I dealing with, because the cornea, as Dr. Rehab mentioned, was crystal clear. Since it's crystal clear, it can't be the graft's decimen. Doctora, can you put the picture of the OCT, لو سمحتي?
Yeah, sure.
Yeah, now you see this OCT. If you look at the corneal thickness, Doctora, show them the endothelium of the graft. اللي هو آخر طبقة, the last layer in the cornea. This is the endothelium, that you can see the cells, and it's glistening. So this graft is a healthy graft. I don't have a problem. Now, what do we do to confirm that it's a healthy graft? What other test I can do? Yeah, I did specular. It was 1,780 something. So we had good cells. Now, that's a good sign and a bad sign. It's a good sign because I know that my graft is doing well, and a bad sign, I'm going to lose it soon. Okay? To deal with this, if I was not sure, I was going to inject air bubble. Actually, this was my plan. When the moment I saw him and that image came to my sight, I thought, okay, I will take him now to the minor and inject air bubble. Now, alhamdulillah, I did not do that because injecting air bubble was going to sacrifice my graft forever. Then I elected to wait until the eye gets quiet, since I had a very big space between the cornea and the descent. Now, the other question was, where did this descent come from? This patient had a previous PKP, had lancectomy, had vitrectomy, had silicone oil. Where did this descent come from? So it was missed from the first case, from the first surgery, and probably it is the reason for the failure of the graft he had. Okay? So the take-home message is, you really need to know what tissue you are dealing with, because the management is completely different. Over here, we cannot put air bubble. Over here, I could not even put vision blue and remove this capsule because I don't want to damage my fresh corneal graft. And I don't have a slit lamp on the microscope. The nurse had to hold for me the slit lamp coaxial. Now, I was thinking as a surgeon, and then when it didn't work, I learned to think in a conservative way where we had to use the simple method, اللي هي الياج. YAG did nicely, and that's what we learned to treat with the second eye. The second patient, طبعا هذول 2 patients came to me الأحد الأسبوع الأول الأحد الأسبوع الثاني. And I got shocked first week and shocked second week. And I started to reconsider my skills. What am I doing? What's going on? And this was a message, you always learn. You always learn. حتى إني أنا بلمت نفسي إنه I thought in the first case, who is that surgeon that missed the deciment in the first case? And then I missed the case, the deciment on the second case. So never blame anyone for surgery. You never know what happened with them. يعطيك العافية ريحان. Any questions?
Why do you blame this membrane for failure of the breast?
لأنه
Why graft is vascularized?
بعد كم سنة دكتور؟ أنا جاني الجرافت بعد كم سنة. So probably the endothelium of the graft was trapped behind this. It was not in communication with the aqueous.
So aqueous is not reached?
Did not reach the graft itself, the previous graft. I removed it. I removed it early. ما خليتها تستنى.
So there was no opening in this method?
أبدا دكتور, not even a puncture. Not even a puncture. I think طبعا the first case was a trauma, penetrating trauma. Okay, it was an open globe injury. And post-op شفت retinal scar is very huge. So I'm not sure what did the surgeon see at that time. أنت عارف primary pair enclosure is the basic. So he might have had, he's not young. The trauma happened few years ago. So he might have had weak deciment to start with, and it was detached immediately after the penetrating trauma. He had aggressive surgery before. I don't know. Good. Good.
So sometimes it may not be indicated to remove. I don't know. But sometimes if it is not causing any problems, you may watch for observation.
I didn't feel comfortable to leave it because في بعض الأماكن it was almost touching. Okay. And with a fresh graft, just had surgery done, you don't want to lose one cell at least. So I wasn't able to leave him and sleep nicely until I removed it. للأمانة. I don't know if Dr. Qahtani, what would you do?
The intervention here will be the solution.
or excision. يعني هي مختلفة عن الدالك الدبل تشامبر اللي هي described in the literature that happens after partial corneal thickness transplant. You don't need actually why does it happen دالك أحد يعرف double anterior chamber after LKP? Does anyone know? This space is between what and what? What deciment? This is deciment fold, but the double chamber, you don't have a fold here, you have a double chamber. You have a picture like this. The difference is the surgeon might not have not removed the donor's endothelium and just planted the tissue on top of the patient's deciment. So after you do the dissection of the patient's cornea, you refine and you clean and your deciment is ready, and you want to implant your graft, you are supposed to remove the deciment of the graft. Some surgeons claim that they don't have to remove it and they just place it over the patient's deciment. Post-operatively, the deciment of the donor is still functioning, it's not yet dead. So you will have a double anterior chamber between them. In this case, I don't worry much, I can observe, because I want this endothelial cells to wear off and I want them to become non-functioning. Meanwhile, with time, the patient's deciment will take place and it will attach firmly and the patient will go back to normal. Here it's different. My precious endothelium is trapped. It's completely opposite to the double anterior chamber post-DALC. Did you get this? Yeah, so you cannot leave it without intervention. Okay, تفضل دكتور إحتاني.
To avoid this double chamber, every time you do cornea, this is for the resident and fellow.
لا والله for me.
Because I had this similar case while I was fellow. And after that, after I remove the patient's cornea, I make sure that there is no retained deciments. How to do it? The best way is to take 0.12 forceps and try to touch the iris, to try to grasp small piece of the iris. If there is a retained deciment, it is usually invisible, but you will find glistening appearance, or if you touch the iris with forceps, it will come with to you.
Yes.
So every time you remove the cornea, touch the iris with small forceps, make sure that there is no retained deciment.
يعطيك العافية. Thank you, Doctor. Okay, our last case is a uveitis case going to be presented by Dr. Mohammed Sgehi. Dr. Mohammed has a very serious topic. When I was a resident, we only heard about it. I never saw a case as a resident. But now in our institute, we are seeing at least one case every 2 to 3 months. Dr. Ghazai Thibeti was the I have to say acting consultant who managed the case, and he is here to supervise him. Thank you.
Assalamu alaikum. Masal khair. Initially, we'd like to thank Dr. Ghazai, Dr. Anud. They provided me this case and give me the opportunity to present this case. So, we have a 43-year-old male. He is non-case HIV since 2 years. And he came to our clinic complaining of a progressive gradual decrease in vision in the right eye since last 4 weeks. So in examination, we note the vision in the right eye is 6/26/24 with keratic precipitate, +3 cells, and the lens is clear. In the left eye, it's completely clear. In the fundus examination for the right eye, we note there is the prevascular sheathing and intraretinal and preretinal hemorrhage with multiple yellow patch. It's okay. With yellow, with multiple white necrotic area. So the fundus of the left eye is within normal. We follow up him next day. This is the FFA for the right eye that shows this is a mid-venous phase. There is staining and increased intensity with non-perfusion area. It's presenting, this is the necrotic area. So our impression initially, it was the retinitis with occlusive vasculitis. So the initial differential diagnosis, it was the CMV retinitis initially, The second one, progressive outer retinal necrosis. The third one is the acute retinal necrosis. So our plan, we admit this patient. We did for him lab workup for the CMV, IgG, IgM, and the CD4 count. And with the full blood workup, because we're going to start antiviral, so we have to assess the renal function test, refer him to ID consultation, and this patient's already known from the ID team. And to start the Bridford and the Cyclo, he has anterior chamber cell reactions. On the second day, on the 4th of October, we start already the first dose of the ganciclovir intravitreal. The vision was 6/24 in the right eye. Still there is keratic precipitate. The AC reactions become less. The cytomegalovirus IgM is positive, and the cytomegalovirus viral load is 1,299. We follow up him in the 8th of October. The CD4 cells count was 40 cells per microliters, and the vision in the right eye was just slightly improved, 6/12. There is a corneal dusting, and there is still the scatter hemorrhage with white patchy area, but the macula is spared, but there is no retinal detachment. In the 10th of October, the patient admitted in ICU. He developed encephalitis, loss of consciousness. The Glasgow Coma scale was 9/15, and he is already on heart therapy and with ganciclovir. So the corneal still there is a dusting, fundus still the same, scattered hemorrhage with whitening patchy area, and there is no retinal detachment. In the 16th of October, still he was in ICU. The Glasgow Coma scale slightly improved. Already continue on antiviral systemic medication, and there is no change, no more change in the fundus examination, and at this time it's already received the second dose of the ganciclovir. In the 26th of October, he received the third dose of the intravitreal ganciclovir, and the cytomegaloviral load, it's become low, that's become 71. Previously it was 1,200. The visions become 6/18, and the fundus photo, or the fundus examination, there is a scattered hemorrhage with whitening patchy area in the macula, sparing the macula, but there is no retinal detachment. In 2 of November, he received the fourth dose of the intravitreal ganciclovir, already continuing the induction treatment of the antiviral. The vision 6/30. The fundus examination, there is no more change. In the 9th of November, the vision and the examination, it is the same, no more change. And in the 15th of November, he received the fifth dose of the intravitreal ganciclovir. He has already continued the systemic antiviral. The vision starts to become improving 6/18. The scattered hemorrhage has become less, and there is no retinal detachment. So on the 29th of November, he received the sixth dose of the intravitreal ganciclovir, and the CD4 counts become up now. It's become 68 cells. The previous one was 40. So this is the final pictures for him after he received a sixth dose of the intravitreal with a systemic heart therapy induction dose from the ID and with a ganciclovir. So this is the compare between two pictures. The previous picture, there is prevascular sheathing, there is scattered the whitey patching necrotic area with retinal hemorrhage. Rather in the left eye, it's the necrotic just presenting in the periphery. There is a little small of the non-perfuse vascular. So in CMV retinitis, it's initially associated more with HIV patient. It is involving a full thickness retinal infection, which leading to the blindness and the retinal detachment. Blindness because it is involving, if it is involving the macula or the optic nerve, it's leading to the blindness. And from the break, from the necrosis leading to the retinal detachment break and leading to the rhegmatogenous retinal detachment. It is a 40% bilaterally. So the cytomegalovirus, it's a double-strand DNA envelope virus transmitted through the body fluid. This virus affecting the host cells of the nucleus and the transcript on DNA and produce the viral particles. Epidemiologically, this disease affecting the most common, the HIV patient, then the neonate, then the recipient from the bone marrow or the organ transplant. But it is the most important risk factor according to the longitudinal ocular complication AIDS patient study that show the single most important risk factors when the CD4s become less than 50. Before induction, the HAR therapy or the CAR therapy, it's the same name, but depending on the induction of the treatment, it is the incidence was 30% in each HIV patient. So the common risk factors for the CMV retinitis, the first one is the HIV patient. The CD4s will become less than 50, and even if we give the topical intraocular immunosuppressive like steroids, it's a risk for the CMV retinitis. So the CMV retinitis is a clinical-based diagnosis with immune status of the patient. So if we are going to differentiate between the CMV retinitis and the acute retinal necrosis, the CMV is affecting the immunocompromised, while the acute retinal necrosis, the immune competent and compromised. The CMV is involving the posterior pole, but it is initially involving the periphery, then follow the vasculature to reach the posterior pole, while the acute retinal necrosis, it is initially starting in the peripheral. The CMV with prominent hemorrhage, acute retinal necrosis, less hemorrhage, more vitritis in acute retinal necrosis, less vitritis in the CMV. The CMV, the inflammations involving the peripheral patches with the faucet angiitis involving artery and vein. Acute retinal necrosis is most commonly involving the arteriole, and we start the medication, the CMV, with the valganciclovir, while in the acute retinal necrosis with acyclovir. So the most common presentations for this patient, the most common is asymptomatic, or might be present with floaters, or the decreased visual acuity in one eye because they initially starting unilateral and then follow bilateral. Or the photopsia starting, he develop a break, then develop the retinal detachment. So in examination, we'll note there is multiple yellow-white hemorrhage. With hemorrhage, it is a pizza bite sign, starting in the periphery and follow the vasculatures. And we have the pattern for this disease either fulminant, involving the macula, posterior pole with more hemorrhage, while in the indolent, it is less hemorrhage and is more granular. 1/3 of patients, they develop rhegmatogenous retinal detachment. And this might be associated with acetylated keratic precipitate, the CMV uveitis, and the vision impairment is caused by the necrosis in the macula or the optic nerve. In the laboratory test, the PCR is not specific and sensitive. We are going to take the IgG and the IgM to follow the activity of the CMV retinitis, and the CD4 to build up the immunity and follow up the patient, and the CMV viral load with a general lab workup. So in the management, in the CMV retinitis, initially we refer patient to the ID teams for the HAR therapy or the CAR therapy to induct the dose. And the first line therapy for the CMV retinitis start with the valganciclovir. But if we are going to take this medication one by one, the valganciclovir, the induction dose is a 900 milligram BOPID, followed by the maintenance dose, while the ganciclovir 5 milligram IV BID, followed by 5 milligram maintenance dose. Foscarnet, it is 90 milligram per kg BID, followed by the 90 milligram per kg intravenous daily. If the patient involving there is a sight threatening, we have to give him intravitreal injection. And we'll come and discuss about this medication and what the review articles are supposed to start the treatment for this patient. This is the modality of the intravitreal. It is, we have the ganciclovir, we have ganciclovir implant, and we have foscarnet, and we have the pseudovir. The ganciclovir is 2 milligram twice weekly for 3 weeks, then maintenance dose 2 milligram. We will come and discuss them. This is the review articles that show, depending on the longitudinal study of ocular complication of AIDS patient, that show this intravitreal injection alone worse than ganciclovir implant or the systemic therapy. The progression is found 96.1 per 100 eye for those patients receive only intravitreal injection. And the visual acuity is worse than 200/50. It is present in 84.6 each 100 eye. And 22.3 per 100 eye for the ganciclovir implant, and the visual acuity is worse than 20/40 for 32.8 patients. 16.5 it show for the systemic therapy, and the the visual acuity worse than 20/40, it's presenting in 18.1. So the study found combination oral and intraocular therapy decrease the risk for the new severe retinitis and decrease the progression of the severe retinitis. So regarding the systemic ganciclovir, this medication, initially this viral depending on the viral kinase and the DNA polymerase. So our medication to try to hit this mechanism. So the CMV DNA polymerase, it's bind and inhibit the replication. So in this study that show the systemic ganciclovir extend the progression of the disease from 16 to 42 days. While in the ganciclovir implant that show delay the progression of the CMV retinitis from 15 to 226 days. In Foscurant, use this medication in case of the resistance with the ganciclovir. So that show delay in a progression from 3.2 weeks to 13.3 weeks. Intravitreal Foscarnet, we can use it as an injection, 2.4 milligram, and the retrospective study that showed delay in progression 15 week and stable the visual acuity or improved in 66%. The Cidofovir that show delay the progression from 22 days to 120 days. And the valganciclovir orally, it is that show regarding 160 patients that receiving the ganciclovir IV and the orally, that show there is no difference between them, and it is delay progression 160 days. So we continue with the systemic medication until the CD4 counts become greater than 100, then start to follow up the patient and give him maintenance dose until to be the CD4 more than 100 for more than 6 months. The longitudinal study for the ocular complication that showed for those patients, they recover the immunity after the heart therapy. They compare between 31 continuing the maintenance and the 37 stop the maintenance, that show there is no difference between them. So the most common complication with the CMV retinitis, and it is leading to the permanent blindness. It might be retinal detachment from the necrotic patchy area leading to the break and the rhegmatogenous retinal detachment, immune recovery uveitis, cystoid macular edema, and epiretinal membrane formation. So in conclusion, the CMV retinitis is a common with HIV patient. The common presentation symptom is asymptomatic. The study that show the combination oral and intraocular decreased risk for the new CMV retinitis and the progression of the CMV retinitis. And continuing the maintenance therapy until the CD4 become more than 100 and to maintain the dose for more than 6 months. And the study that showed the CD4 less than 50 is the single most important risk factors. The intravitreal injection alone, worse than ganciclovir implant or systemic therapy. The most common complication is the rhegmatogenous retinal detachment and the immune recovery uveitis. Any question? تفضل دكتور.
They will have more.
And he's already started 2 induction heart therapy before. He's known case of HIV more than 2 years, and he received 2 doses for the induction for heart therapy 2 times. Then after that, he started to complain from the gradual decrease in vision. So that's why it's anterior uveitis coming from the recover immune uveitis.
Build up immunity. طيب يعطيك العافية دكتور عمر صراحة كانت very nice question. So for CMV retinitis, our main first as a treatment is a teamwork. It's not only ophthalmologist or ID, it's both of them, and our main objective first is to build up patient immunity, to build up his CD4. Because if you are building the immunity, patient will improve. Even if patient is not in heart regimen, whatever you give intravitreal or intravenous, it will not help. So building immunity is important things to start with. Then starting patient in IV and intravitreal and antiviral, and you're observing the patient and you keep giving him intravitreal injection till you see the resolution of the infection. And at the same time, improvement of the CD4 numbers. Unfortunately, this patient, alhamdulillah, it goes fine, but the main concern here is after the treatment, what will happen. Now the patient, almost his retinitis and his active inflammation is resolved because of everything that he received, starting with the heart regimen, with the IV antiviral, with topical. Now we'll stop the antivitreal, no more intravitreal because the inflammation is subside. Patient will be kept in heart regimen. If his CD4 is more than 50, he will be less prone to CMV. But what will be the bad thing that will happen, may happen later on, if the patient develops retinal detachment. And this retinal detachment case is really difficult to deal with because you are dealing with a necrotic tissue. And it really would be a bad day if he had RD.
So now
heart you mean for IV ganciclovir? Yes. They give it for 6 weeks, and whenever the patient CD4 is yes, then the patient is less prone to develop CMV retinitis. I don't know if Dr. Suleiman has to.
I would like to thank you for the excellent presentation and to congratulate you, Dr. Ghazai, for the management of this patient. I have a comment on management of these cases. If you have the facility, I think AC tab and PCR is of value. In acute retinal necrosis, it has high specificity and sensitivity. If you find the viral DNA by PCR, then it is highly likely that this is a viral infection. The second thing you mentioned about when you compared ARN and CMV, you mentioned the typical form of ARN, which is peripheral, that
yes,
progress peripherally and posteriorly. There is another form that is atypical,
yes,
that starts posteriorly, atypical necrotizing retinopathy.
Yes.
That could be caused by herpetic, meaning that herpes simplex virus type 1, type 2, and zoster virus. The third thing, I did not hear you mentioning that the findings, when you described the picture, that this is a frosted branch angiitis picture.
Yes,
this is the typical frosted branch angiitis picture. Regarding the lifelong antiviral prophylaxis, in general, this is, at least in acute retinal necrosis, this is not agreed on. It is a controversial issue. I have seen patients that developed acute retinal necrosis in the other eye after 15 years from the first eye being involved. Some people, they recommend that keep the patient on lifelong antiviral, at least low dose of antiviral Valtrix. But not everybody does that. So the door is still open. We don't know what to do. I personally prefer that I keep the patient on antiviral therapy as long as I can if there is no renal problems. Regarding guys again cyclovir and lifelong prophylaxis, I'm not sure, but if I was in your position, I would leave it to the infectious disease specialists.
It's already discussed with them.
If RD develops in these cases, you have to keep in mind that lifting the hyaloid will be difficult. You'll have multiple breaks, and you'll probably have to put a screw buckle with the vitrectomy, and you will have to leave the oil for a very long time, maybe indefinitely.